your hands in the air, wave them like you don't care if you can hear my voice. Beautiful, beautiful. Outstanding, outstanding. We've got volume, screen sharing, and recording. Over here, we have volume, screen share, recording. We are live. Lower hands. Okay, please make sure you're in a capability of answering for roll call. If someone doesn't answer for roll call, but they type their name at the chat on the bottom, just speak up for them, please, and let me know so that I can mark them here and not. Aaron Vaness. Okay, I'm going to drop Aaron as a no-show. Aaron Sonnefeld. I'm going to drop as a no-show. Brittany Bolger. Aaron Palmer. Stand by. Stand by. Stand by. Was that Aaron that said he's here? Aaron Palmer, did you say you're here?
Yes, sir. I'm here.
Okay. And make sure that you say your name.
Ariane Palmer.
Not right now. Gotcha. I got you. Cameron Pierce. Cameron Lanford. Charlotte McMahon.
Charlotte McMahon.
Krista Joby. Christopher Mooney.
Christopher Mooney.
Yeah, there we go. Sierra Mitchell. Claire Kimichek. Cynthia Earhart.
Cynthia.
Hi, Cynthia. Dylan Bell. Emily Burke. Faith Pinkney. Jacob Mulkey is a drop. Jennifer Hernandez.
Jen.
Salem. Juket Salem. Okay. Kelsey Hearing. Leslie Williamson. Maddie Dole. Makaya Davis. Makaya is a drop, but I'm going to hold on. Maria Barufi. Mazara Rocha.
Maizara Rocha.
Yeah, Mazara. I got to roll that. Mazara Rocha. Okay, you're here. Mitchell Hinton.
Mitchell Hinton.
All right, let me mark you white, not red. Nicole Tenorello. Noah Wilson. Ryan
Noah
Jackson.
Wilson.
Okay, Ryan Jackson. Ryan Richards. Sarah Coker. Shane O'Connor. Sierra Altman. Stephanie Wilcox. Todd White. Tony.
Here.
That's Todd here. Thank you. Tony Warwick.
Here.
And I think that's Tony that's here. Vishnu Guvadata. No, that was wrong. That was horrible. Vishnu Gudva. I'm going to just wait. Go ahead, Vishnu. You're here. Okay, I'm going to put that down. Vishnu Gudivada. That's it. Wilson Maddox. All right, Stephanie Wilcox, you're not here. Sarah Coker, you're not here. Shane O'Connor, you're not here. Ryan Richards, you're not here. Maria Brufy, not here.
I'm here.
Is that Maria? Who's I'm?
Maria Brufy.
Okay, there you are. Makaya Davis, you're not here. Maddie Dole, you're not here. Kelsey Hearing, you're not here. Faith Pinkney's not here. Emily Burke's not here. Dylan Bell's not here. Claire Kimichek is not here. Sierra Mitchell's not here. Krista Joby.
Sierra Mitchell's here. She's having typing and microphone issues.
Sierra Mitchell is here. Krista Joby's not here. Cameron Pierce is not here. Brittany Bolger's not here. Everyone else, I have you. Remember that if you're not here in the live session, you are to complete a lecture assignment associated with week number 2. All right, tonight we are doing chapters 4, 5, and 6. Arguably, they're pretty tough chapters, so we'll get into that the best that we can. Give me 2 seconds to not burn a pizza. Hold on. Stephanie Wilcox is here. I got it. Are there any questions for me before we begin lecturing? Your books will be obtainable in lab. Some of you have already gotten them. Some of you have not. A lot of you are afraid to blow my phone up. If you don't blow my phone up, I'll probably miss that you were here at my house and you'll leave for no reason. So I've told you guys 100 times. I'm telling you again. Call me once or twice. I would prefer twice if I don't answer. Now, if I don't answer you again, it's because I'm probably on a flight. But on a typical basis, I got so much going on that I might not be able to get to you fast enough. So if your number is not known in my phone, I'm going to believe that's a telemarketer. So call me back again. And when I see that it's 2 missed calls, I know it's a real person and I'm going to call you right back. So I've tried to do pretty well with that, but sometimes it doesn't go all the way as I plan. So most of you have your books. If not, you'll have your book during lab. Kelsey Herring, I'm going to go put you in. Miss Shanna, calm down with the noise there, friend. You need a plate, not a saucer. And you don't need to put any of that in the microwave. Just put that standing upright in the microwave for the amount of time that it says. Strong work. It is a black screen because we haven't put the presentation up there yet. 4, 5, and 6 if you're following along in the book. Why is it not? I got to force it to load the presentation. It is not normally. Let's see why it's having so much trouble. Okay, let's just open them up from a PowerPoint perspective. Stand by. Okay. All right, we'll just do screen share for PowerPoint, and we will start with documentation since no one seems to have any questions. Raise your hand if you can hear me. Okay, great. That's fine. Thanks. All right, since I'm going to be over in the PowerPoint and not through the actual Moodle itself, I won't be able to see anyone typing, so please don't let me miss anyone's message because I won't be able to see both. So chapter 4 is about communication and documentation, which is important, but we have a lot of meat and potatoes to cover tonight, so I'm going to kind of zoom through this and tell you what the testing material is kind of looking at, and I'll hit the really important parts, but that is not to make you think that you shouldn't spend some time in the chapter. How EMS communicates is specific and the methods that we use, so make sure you read the chapter. It's also about documentation, which is our patient care reports, which we are going to know as PCRs. So remember that a PCR means patient care report. And I remind you that that's a permanent living document that is forever with the patient. So after every single encounter of patient care that we perform, we're going to write that up and say, this is what we found, this is what we did, this was the result of what we did, and we drop the patient off at the following hospital, or maybe the patient refused, whatever the case may be. We're going to document that. So we'll talk a little bit about that. Obviously, since we're out into the field and we're dealing with patient care, we're going to have to communicate with EMS-related communications like supervisors and dispatch centers. And then we also have to communicate with the hospitals that we're delivering care to. So we'll talk a little bit about that as well. These are the reasons that you need communication, and I already spoke to our documentation. Medical terminology, we're going to learn a little bit about this week. However, the chapter is going to be very clear that there's a time for medical terminology and there is a time that we should probably not be using a lot of big words on purpose to make ourselves look smart. And so the information you need in that regard is that if you're given patient care turnover from person to person, if you're given an in code to the hospital, that is not a time to use the biggest words that you can think of and to make yourself look really smart. It's all about the patient, and medical terminology, especially terminology that's used incorrectly, could result in a malpractice issue, could result in us not doing the best we could have done by the patient. So where is medical terminology best reserved for? In your patient care report. That's where you can go all out on your terminology and your big words, your $9 anatomy words. But when you're talking to a person, whether that's on the radio, whether that's at bedside because you're giving patient care turnover, we don't tend to need to use $9 words during that change. All right. I'll let you read about how human beings communicate because that's on you. Here's our permanent medical record, is what our documentation is. Make sure that it is complete and accurate. If you didn't put it in the report as having happened, then it didn't happen. You can go back after you complete a report and write an addendum, as we have discussed in class, but once the patient care report is called into question, you certainly can't write an addendum then. So whatever you have written there is whatever it would be. So keep that in mind. Don't rush these reports because they are forever. I'll let you deal with how we, again, speak to human beings and how they receive our message and how they give it back. I'll let you look at that information. You should keep in mind that genders are different, people are different, cultures are different, and so talk to people respectfully. Be careful who you're dealing with, whether it's a young person or an old person or even a pediatric person. You got to be careful not to assume anything. If it's an elderly person, don't assume that they're deaf because not elderly people are deaf. Don't just touch people without their permission because some cultures are very against touch. It's not very approved. So, there are cultures that also don't really care for direct eye contact. Such as some Asian cultures. So you got to kind of be aware of your body language. You got to kind of be aware of your tone. I'm definitely not the best at that, that's for sure. But we should work on it, and we should be thinking about whether or not the message we're sending out is being received well by our patient. Hold on 2 seconds. Okay, here we go. So keep those things in mind. People will get upset with you and your language communication skills, whether that's body language or your harsh tone. It says use open-ended questions as much as possible, and so that's an interview technique. If you give people yeses or nos, then they'll give you yeses or nos, and they're not necessarily accurate. So opening up a dialogue and having a communication with the patient allows for you to learn more information from them. There are some communication tools there. Of course, we want you to be compassionate. I'll let you read this stuff, which you should do. You should go through and read this. These are the golden rules here. It says that some cultures don't like eye contact. And then on this page, it says always make eye contact. So anytime you see always, at all times, forever, every time, you should be suspicious of that, because that doesn't work very well in life, which is a gray area. Life is not white and black. It is not yes or no. It is typically a blend of those things. So be careful with that. Always introduce yourself to people. Say who you are. Say you're going to take care of them. That is a big deal. Always tell the patient the truth. But you should do so strategically in a way that doesn't make them worse. It makes them hopefully better, or at least don't do harm. All right, I'll let you read that stuff. You need to realize that older patients will typically tell you they're not in pain when they are. That's twofold. It comes from generational thinking of we're supposed to be tough. And then it also comes from the fact that as we age, we do not receive pain as quickly and efficiently as we did in younger time. So they may not feel the pain as much as they should be feeling it. So don't undertreat them because they're not necessarily complaining of gross 10 out of 10 pain. Children, of course, you've got to be careful with. We don't want to scare them. When 5 firefighters, 2 paramedics, and EMTs walk in the room with 5 police officers, they get a little frightened. So try to think about how you're going to interact with pediatric patients. That's very important. Typically introduce yourself, get down on their level, don't stand over the top of them. Let them play and touch and mess with your equipment. That tends to make them feel better about you assessing their vital signs. Remember that they don't know what does poke them or doesn't poke them. So you've got to kind of prove that, hey, this particular thing I'm trying to do to you is not going to hurt. It doesn't do any harm. It says speak professionally to children because they really like that. Just kidding. If patients have hearing aids and stuff like that, make sure you bring those with them to the hospital. I don't care for this slide because I think it makes people give themselves a best go at something they don't know about. I don't think we should be trying to speak a different language or use sign language with no specialized training. Because you're going to mess it up, and that's quite offensive, and they're going to get mad. We do have a language line, so if the patient does speak a foreign language, you can call the language line, and they can help you. They have lots and lots and lots of different languages on the other end of the phone. You do that by calling dispatch, and they were able to patch you through and help you with language. For guide dogs can come in the ambulance. Make sure you know that. We're not really allowed to ask a lot of questions about guide dogs. What we can say is this dog helping you with some type of disability? And is the dog trained and able to follow your commands? You can ask those things. And potentially you need to bring the dog with you in the ambulance. Out of that, make sure when you're given a report that we don't use $10 words. Let's be as clear and concise as we possibly can. These are the things that your patient care report serves to provide. So continuity of care is a big deal. It's the legal documentation of what you've done. It also is used from the service inside as to the data of your call. Did you do what we were supposed to do for this particular patient complaint? Are we meeting the standard that we say we meet? That's how we're going to obtain the information, is by going through patient care reports. And so every single patient care report that you do is going to be looked at by another one of your peers to see if your care was as good as it should have been, to see if we've gotten all the information we're supposed to get, like name and date of birth and social security number and phone number. And then there's a lot of signatures that we have to get. So they're going to also want to make sure that you have gotten those legal signatures. I think I heard someone stick their hand up. Let me make sure that wasn't a fluke. Jen Hernandez, do you have a question? Or was that a mistake? Your microphone works, Jen. Is it only guide dogs or emotional support dog? If it's not covered by the ADA, we don't have to acknowledge it. There's no such thing as an emotional support dog. That's 2022 verbiage from CNN. We don't honor that. We honor legal, trained, and recognized disability animals. Most of those are dogs. And so if they say that this is an ADA dog, then you know that it is, and you've gone about your business. So no, we will not take Bubbles the Chihuahua because it makes you feel better. That tends to provide a sanitation problem for our environment. My child is unaware of his noise over there. My apologies. So those are the reasons for your patient care report. We always document chief complaints and the vitals of the patient, which we'll come to know mean these things here listed on the screen. So there's tons of different patient care software reporting systems. In our state, we use ImageTran, EMS Charts, ESO. There's tons of them. So whenever you go to your services, they're going to train you to use that kind of material, and they're going to teach you how they want you to do reports. You need to know that they have the right to tell you how to document your patient care encounters from two angles. They're looking to make sure you're meeting their standard, and they're also looking to make sure we can appropriately bill for this call. If EMS isn't able to bill for the call and return some type of monetary value to the service, then you wouldn't have your job. So a lot of our patient care report requirements are making sure we're meeting the mark for billing, which can be a little bit annoying. The narrative section should only be what you couldn't say with the check boxes. You're going to come to find that patient care reporting systems have most of the things that you need in a checkbox section where you just click whatever applies to the patient. Your narrative should tell the story that you couldn't tell with those check boxes. You don't typically want to be repeating a lot of stuff in the narrative. You don't want to double document, because when you do that, it tends to leave you up for the chance of mistake. You said in one part of the report that you gave 2.5 milligrams of albuterol, yet in the narrative you said you gave 5. So then which was it? And so in the eyes of a jury, that might make you look not as competent as you should be. That might make you question the entire chart instead of just that one mistake. So be aware of those things. Make sure you're not double documenting, because it might leave you to document something a second time incorrectly. In the state of South Carolina, all patient care reporting is conducted electronically. Remember that your report is where they're going to get the information to sue you from. So whatever they have is what you gave them. Keep that in mind. Whatever they have to use against you in court is what you gave them. Keep that in mind. All right, moving into some communication things. How do we talk? This is the stuff I'm going to tell you about because it's testable material. All right, we communicate typically on radios, but you might work at a service that communicates mostly by cell phone. Almost every single ambulance does have a cell phone on it, and they have portable radios. So you need to know what type these radios are. A base radio is one that's in a building and it doesn't move. A two-way radio is a radio that can move around. So that's the radio that's in the ambulance, okay? That is a mobile radio, okay? And then your portable radio is what you keep on your person. So I'm going to go back over those. A base radio is in a building, base for building. A mobile radio is the radio that's in your asset. So that could be a quick response vehicle, a Ford Explorer, a Chevy Tahoe. It could be your ambulance. That's a mobile radio. That radio is moving around. And then the portable radio is the one that you have on your body. Your portable radio is your safety net to get help to you. So if I were you, I'd be very confident in my ability to use that portable radio. I'd know where the channels are. I'd know who I'm talking to. I'd know how to get wherever it is that you need to get on the radios. The radios can talk to a lot of people. So you want to make sure you know how to use that radio, because should something poor happen, and by poor I mean not so lovely to you, maybe you get into some type of physical altercation with a patient or a bystander, you want that radio to key up immediately and get your help running your direction. You don't want any delay because you were on the wrong channel or because you don't know how to work that radio. So remember, your portable radios are a lifeline, and you should make sure you're very efficient with them. You should constantly make sure you're on the right channel. You should constantly be able to move that radio around to wherever you need it to be, and do so preferably by, unconsciousness. You should practice and practice and practice it so that if some mistake came, you'd be able to get help. A repeater-based system just means that one person keys up the radio and the signal is not strong enough to go all the way to the person who's receiving the message. So then it must hit a third piece before doing so. So in this case, over here, you see the little tower on the left is sending out the signal. The big tower is receiving it and then repeating it at a better receivability. I'm not going to get into megahertz and 800 versus VHF and all of that. Just know that a repeater system takes a signal that probably couldn't have gotten to the provider by itself, and it repeats off of another tower, making the signal and the message stronger so that you can receive it. So if it didn't go straight from A to B, it was repeated. So if it's A, B, C, that is a repeater-based system. A being one EMT, B being the tower that's repeating, and C being the receiver. Most of our radios and stuff are digital and electronic. So you're going to hear very good communication equivalent to a cell phone in most areas. And you can use your cell phone as well. We also have the ability to send anything that you would normally be able to send by Wi-Fi. So our vital signs are sendable to the hospital and to ALS backup and to supervisors and the physician that governs us. We take the vitals that you got out of the monitor and we load it into the report using Wi-Fi. So a lot of the stuff that we use, the equipment, that all loads up into the report and it can be sent to physicians and other people if it's needed. Telemetry means EKG monitoring. So we'll look at that as like placing a patient on a 4-lead or a 12-lead. Half the lab last week did not get to see that because we were moving too quickly, but half of you did get to see it where you put a patient on the cardiac monitor and you're seeing their heart rhythm. Well, we can send that to hospitals as well. We do have sat phones. They're very expensive. For example, on the helicopter, I have a sat phone that will call anywhere in the world to anyone who can receive a satellite signal. And it's very expensive to do that, but it gives you the ability to talk to people kind of no matter where you are on the planet using satellite and GPS technology. So there's that. Remember that on the way to the hospital, every single call, we're going to give a radio encode. We're going to pick up the phone or the radio normally, depending where you work. Some places do call on the phone, but we're going to pick up the radio and we're going to dial up to Trident or we're going to dial up to MUSC and we're going to give them an encode and say, hey, we're coming to you, just letting you know, prepare for this patient. So that when we get there, they're not starting from zero. The Federal Communications Commission does regulate all radio traffic in the United States of America, meaning if you're cursing on the radio, if you're being funny on the radio, if you are doing anything silly that isn't for what the purpose of that radio is, you could potentially be looking at fines. So how we talk on the radio is important. It's easy to get jokey and silly on the radio, but we do have to keep it to a minimum because it is being monitored, it is being paid for, and it's not a right, it's a privilege. So they could, if it got ugly enough, they could take this right away, this privilege away, rather. So keep that in mind. Here's an example of a portable radio talking. Remember, that is your lifeline to get help. So we also talk to physicians on radios. I already talked to you about giving patient reports. You'll learn how to give encodes kind of as we go through class. We're not going to hit on that a lot but we will kind of do a couple of examples of that and just let you see it happening. Also, when you go onto your clinical ride-alongs, you're going to see encodes get given every time. Maybe they even let you give an encode. Here's a reminder that you have medical control physicians in the field, and if you're doing everything you're doing without them present, it's offline. If you're doing it with a doctor present in some way, shape, or form, they're actively telling you what to do, maybe by radio, maybe by phone. That would be online medical control. Make sure you know the difference in those. You know the role of medical control. We've talked about it a lot already. There are doctors at the hospital talking to us as well. Anytime you are acting with medical control, it is important from the book to remind you that if a doctor gives an order, the way we do that is to repeat the order verbatim back to the doctor to make sure that everything was heard and received the exact way they want it heard and received. And so if you were saying, I can give my first albuterol treatment to the patient, but if I want to give a second one, I've got to call for an order. So say you're on Medic 1 and you've got an asthma patient and you give them one breathing treatment and they get a little bit better, but they're not as good as they could be. And so you decide I'm going to give another. So you pick up the radio and you call Trident and you say, hey, Trident, it's Medic 1, BLS crew. I've got an asthma patient here who is having a good bit of trouble breathing, and we have given one treatment of albuterol, but we don't have permission to give the other one without calling, so we're asking you for permission to give another treatment of albuterol. The patient still has wheezing. The patient still has trouble breathing. They're conscious. They're oriented. They're speaking to us in broken sentences, and we'd like to give them more medication. Can we do that? And they say, okay, BLS crew, go ahead and give the patient 2.5 milligrams of additional albuterol. And then you would say right back, okay, per Dr. Miller, I'm going to give 2.5 milligrams of albuterol in addition to my first treatment per Dr. Miller. And they say, yes, that's correct. Okay, then you can give it. So make sure you know to repeat that order verbatim. If for whatever reason you couldn't be sure what the order was, you wouldn't follow it. You wouldn't risk the patient's well-being if you weren't able to verify that order. So keep that in mind. Obviously, we have a lot of equipment. I'll let you read through that. And we are at the questions. Please feel free to speak up. What do you think? So if you've already had some cultural classes, you know that A is a possibility.
A alpha.
Yeah, that's what I would have gone with too. However, they're going with the more global term. So they're going with cultural imposition, which is kind of a butthole thing to do since ethnocentrism is exactly that. So I get why you would have gone with A, and I would have gone with A too, but the answer is D. So keep that in mind. Communicating with an older patient. Which one of these things applies? Speak up. What do you think?
A.
Well, let's look at the other one. Step back and avoid making patient uncomfortable. Nah, silly. Raise your voice to ensure they're not deaf. That's stupid. And obtain all the information from everybody else. Well, that's stupid. So I have to go with A2. Very good. While caring for a 5-year-old boy in respiratory distress, what should you do? I hit on this specifically.
Delta?
Delta, allow a parent or caregiver to hold the child if a situation allows. That's absolutely a good answer. C is a good answer. Avoid alerting the child prior to a procedure, except it's not meaning alert as in, oh God, here's a procedure. It means that you are not to scare them. It doesn't mean what you're wanting it to mean. If they were saying, make sure you prepare the child, that would be great. So it's the opposite. So I agree. I'm going with D as well. Which of the following pieces of patient information is least important in giving report to the nurse or the physician? So all these are kind of important things, but here's a good question where you've got to choose the most accurate answer.
B.
Yeah, familial history is important for diagnostics. It's not important compared to the other things here. So I agree. Which of the following statements about PCRs is true?
B.
B is true. No, it
I
can
can
be
see.
used. It can be used for billing. Yes, it helps ensure efficient continuity of patient care. That is for sure true. So C, Charlie, is a good answer. B, Bravo, is a bad answer because remember, the physician of our services cannot bill the patient, but the service can bill the patient, and they do, and they should, because otherwise we would not have jobs. Device receiving low frequency signal and then transmitting it to a relatively higher frequency. How did it do that?
C.
Yeah, it repeated it. When treating a potential hostile patient, how would you diffuse that situation?
B.
Is that Bravo or Charlie? I can't hear what. Yeah, Charlie. Speak calmly, speak confidently and slowly. Don't threaten them. Don't say I'm bigger than you, because then they're going to have to prove it. All the following are functions of EMDs except we've told you before that when the patient dials 911, the emergency medical dispatcher goes right ahead and starts care from the phone. Which one of these things is not true?
Delta.
Delta is not true because that would need to come from a physician or a paramedic, depending where you are and where you work. After receiving an order from a doctor, what should you do with that order?
Delta.
Delta.
Yeah, that's an easy one. When requesting medical direction for a patient involved in a motor vehicle accident, you should avoid what?
Delta. B.
I like one of these answers better because there's multiple good answers. Should
Alpha.
you be using? Yeah, alpha is probably the best answer. Should you be using medical terminology? No, not typically, because you're trying to speak clearly and concisely. However, in the old days, we used a lot of radio codes, 10 this, 10 that, signal this, signal that. And doctors don't know what any of that means. And even from one service to another service, they may not have had the same codes as us. So nowadays we talk in clear, plain English. Hey, medic 2, you're responding to a chest pain at the following address. It's a 25-year-old male complaining of chest pain. And that's just how we talk. We don't do 10-15 anymore, which would have been chest pain. We just say what we're supposed to say over the radio in clear talk. So the worst of these options would be using radio codes because a doctor won't know any of that. All right. That's the first chapter under our belt. Let's take a break and we'll do a 15-minute break. We'll come back at 7 and start the bigger chapters. 7 p.m. All right, everybody. If you're back with me, please raise your hand. Still missing a lot of people, so give it a second. Nicole, Sierra, did y'all die? Okay, there we go. Beautiful. Cynthia, is she with you? Mooney? She's on mobile device, so that might be why. Okay, doke. Moving on. Remember, if I am in the chapter, I can't see you. So please let me know if someone has a question that I didn't see. Of course, the best way would be to unmute your mic and to speak up. Make sure I'm screen sharing because I'm not, and that would be a problem. All right. If you can't see my screen, speak up, but you should be able to. Chapter number 5 is medical terminology. And so clearly in the medical world, we speak a different lingo. We have our own language. And so some of that is going to be available to you as an EMT. And so you will have to learn our way of talking if you're going to be in this career very long. And we'll go over the stuff that matters most. Of course, the entire chapter is susceptible to testing, and you should have read the entire chapter and studied accordingly. But I'm going to try to hit on the stuff that I think comes every day, and if you didn't have it, you wouldn't be able to do very well in our environment. I want to also remind the class that the testing material that you're going to see for National Registry very likely will not be using the normal words for something. So, example, they might say you have a 21-year-old dyspneic patient and they go right on about their business. Well, that means a 21-year-old patient complaining of trouble breathing. And so you've got to know these medical terms, or you might even miss questions you otherwise would have gotten right if you had known one simple word out of that question. So medical terminology is going to be pretty important to you. We'll go over the stuff you really need to know. Obviously, we're going to use key terms. Acronyms we use a ton, and you're going to be studying acronyms in here. Symbols and abbreviations we don't use as much. I don't like for you to use them, and I'm going to explain why, so we'll go over that. If you ever want to learn true medical terminology, if you took a medical terminology class in college as a 3 or 4 hour credit class, then they would teach you prefixes, suffixes, and root words. Why? Because even on a word you've never seen before, if you understand a part of it, you can figure the other part out. For example, I know that the A in front of a medical word tends to mean without. So if I see aphasia, maybe I've never, hold on just a second. Hey, puppy. You're not a guard dog. You are a golden doodle. Come here. So on aphasia, for example, I know that A means without and phasia means speech. And so I may not know some part of that, but I can figure it out if I know prefixes, suffixes, and root words. And so you're going to need to try to get that going in you early on in the course. And so here's the example that I gave. Phasia with an S is for speech. And so if you look under the PHASIA, the S means speech or swallowing. And so that makes sense because S is for speech, S is for swallowing. Phagia has GI in it, which means related to the gut. Okay, so if I was dysphagia with an S, I'd have difficulty speaking. If I was dysphagia with a GI, I'd have difficulty eating and swallowing or something to do with my gut. So look at it from that perspective, and phasia and phagia are terms that you absolutely need to know for this class. Anything you see in front of a word that has DYS stands for difficulty. So dys is difficulty. So if we say dyspnea, pnea means breathing, so then DYS PNEA would be dyspnea, and that's trouble breathing. We'll get to that. So know that root words are the main part of the meaning. Cardio we use a lot, and pulmon we use a lot. Cardio means heart, pulmonary means lungs. So if we say pulmonology, that's the study of the lungs, the study of lung care, and cardiology would be the same, but for the heart. And so we use those a lot. You need to know those. A means without, you got to know that one. Brady means slow, tachy means fast. So bradypnea, anything with PNEA. So I'm going to go write that back out, which I hate having to go back from one thing to another. So if I said bradypnea, Where did that go? Why is my cursor on the thing? That would be bradypnea, and brady means slow, and pnea means breathing, so slow breathing. We say tachypnea all the time. So tachypnea versus bradypnea, that would be fast breathing and slow breathing. Make sure you know fast and slow. That's definitely a common one. Apnea is a big one. So if I said apnea, A-P-N-E-A, that means no breathing at all. Apnea is probably one of the most common ones that we see in the testing material. So you definitely need to know apnea. You definitely need to know dyspnea, D-Y-S-P-N-E-A, which means difficulty breathing. Itis is inflammation. You got to know that one. That's a pretty obvious one, I think, but we've used that a lot. Entero is inside of. O-L-O-G-Y is the study of something. You got to know that. We're going to see that a lot. So if we said pharmacology, that would be the study of pharmacy. All of these you should know. I don't think we use arthro a lot, but that's pretty common actually. So you might already know that one. Hepatic is liver. You got to know that. We're going to use that a lot. I'm just making sure you know the ones we're going to use a ton. So bilateral apices, that's something we're going to say a lot. The word bilateral means both sides, and apices means the point of. So the lungs, for example, their apex is on the top. So apex means the point of. And so you have two lungs, and therefore you have two apices. And so you got to know that. Apex versus apices. And remember that apex does not mean the top of them. It means the point of it, where it comes to a point. And so the apex of the lungs are on top, but the apex of the heart, for example, is the left ventricle, and it's pointing down to the bottom. So it's not the same as top. It means coming to a point. Bronchus and bronchi, you need to know a lot of that because we're going to use that a ton. Uni, we're going to use a lot. That's one-sided. So unilateral weakness, for example, we're going to use that a lot. Multi and bi, we're going to use that a lot. I think you know what bi is, and so that'll be easy for you. Cyano is the one on here that means the most. Cyano means to be blue in color, and if you have a blue or ashen color, you're not doing very well. That's not too hot of a condition. So cyanosis, for example, is blue coloring of the patient's lips, skin, ears. That would indicate the patient is in trouble, and they need oxygen and they need blood pressure. Leuco means white cells. So leukocytes, for example, those are white blood cells. Erythro is red, and that's a red blood cell. Cirrho is liver related. So cirrhosis, for example, hepatic cirrhosis would be hardening and a failure to filter of the liver. So cirrho, you need to know that. And melano, we're not going to use a lot, but it just means pigment. It means color. Out of these options, I think cyano is definitely the most important one for you to take home. We're definitely going to use the positions and directions a ton, and they are confusing. So I want you to realize, hey, you forgot again. You're a doodle. Dog. You're not even one type of dog. Get back from the window. Bless your heart. Child would lick you in the face if you were robbing this whole house. So AB, for example, is used in conjunction with AD. So if we say absorb versus adsorb, you got to know the difference between those. And so the way you can remember that is that AD means to add something together. So absorb, AB as in Bravo, it means to bring nutrients on board, right? You're absorbing them. But if you were going to try to stop absorption, you would use adsorption. So in the case of activated charcoal, for example, activated charcoal is an adsorption agent that prevents absorption. So the charcoal adds itself to the bad substance, let's say Tylenol, for example, and the charcoal adds itself to Tylenol. And so then the body cannot A-B as in Bravo, absorb it. So know the difference between those. You also have abduction and adduction. So if you were adducting, then you're moving your arm towards your body because you're adding it to your body. So that's how you remember that. Circum means around. So if I said a circumferential burn, for example, that would be a burn that goes all the way around. So you got to know that one. Peri also means around. So peri-umbilical bruising, for example, would mean that there's a bruise going in a circular pattern outside of the umbilicus. So peri is around. Trans means across. So if it's transdermal fentanyl, that is fentanyl that is administered by putting a patch on the skin. So trans means across. Epi means the top of. And so we're going to use epi a lot. So if it's an epidural bleed, that is the first layer. That would be the top of your dural matters. Supraglottic means above the glottic space. So you guys are going to put in supraglottic airways, for example, and supra means above. So wherever you're talking about, supra would be above it. You need to know those. These are important. These are also really common. You got to use them a lot. Superior is on top of, which makes sense. It kind of sounds right. Inferior is on the bottom, and that kind of sounds right? If something's inferior, then it's on the bottom of. Lateral means to go out away from the middle of your body, and medial means to come in towards the middle of your body. And that makes sense because medial sounds like middle. We'll always talk about the body in lateral. Lateral means on the outside. Medial means on the middle or going towards the middle. Proximal and distal are very common. Proximal means close to, and distal means far away. That makes sense also because distal sounds like distance, and distance is far away. So if you can remember one out of the two, you can probably get the other one correct. Proximal is close to, distal is far away. Superficial is not deep, and deep is deep. That's stupid. But that's the truth. So superficial is on top, and deep is underneath and within. Ventral and dorsal, we don't use a ton, but you're going to find some that do. Ventral means belly, dorsal means back. We'll go with it that way. So if the ventral space is talked about, that's belly space, and dorsal tends to talk about the back. Palmar and plantar. Palmar is your palms, and plantar is your bottom of your feet. So keep that in mind. Apex, I remind you, is the point of something. You have the apices of the lungs and you have the apex of the heart. The apices of the lungs point up and the apex of the heart points down. All right, we've described those. I'll let you go back and look at them. Flexion and extension, again, remember one and it'll help you remember the other. If you extend it, it's away from the body. That makes sense. And so then flexion must be bending towards the body. So if you flex your knee, then you're bending it like it normally bends towards your body. There's abduction and adduction. Again, I already talked about those, so I'll let you look at that. Bilateral we've discussed, and that's going to be a long one that we use a lot. Unilateral is used a lot. The abdomen is spoken of in 4 quadrants. The right upper quadrant of importance handles the liver. The left upper quadrant of importance handles the spleen. The right lower quadrants tend to have the appendix, and that's what worries us in that area. And the left lower quadrant is full of gut. So if I ask you what organs were really important in each quadrant, be prepared to name that. So right upper quadrant, liver, left upper quadrant, spleen, right lower quadrant is the appendix if they still have it. And the left lower quadrant is typically just gut. The caveat to that is the female patient. The right lower and left lower quadrants of a female patient also carry the fallopian tubes. And the fallopian tubes can get blocked, and they can get blocked by an ectopic pregnancy, which is an egg that was fertilized by a sperm and did not attach into the uterus. It attached elsewhere, and that can rupture the fallopian tube. And so if a childbearing age female, which is anyone who still has a period, is having lower abdominal pain. That worries us a lot because it could be an ectopic pregnancy. Ectopic pregnancies burst and they result in internal bleeding, and that is a surgical emergency. So it's important that you understand what's in these quadrants and that we do break it up into 4. We'll talk about that a lot. These are super, super important. You're going to come to know that the treatment of shock is high flow oxygen, blankets, and appropriate positioning. When we say positioning, this is what we mean. Prone is face down. Supine is flat on your back. Semi-Fowlers and Fowlers is sitting up with your feet extended. So think about a patient who's on a stretcher or on a backboard. If you were to raise just their head, shoulders, and their trunk, it would be semi-Fowlers or Fowlers. Semi-Fowlers is at a 45-degree angle. You've got to remember that. That's a test question. And Fowler's position, also known as high Fowler's position, is at a 90-degree angle. So basically the patient is sitting upright. So their butt and legs would be extended out, sitting on the stretcher, and their body, their head, shoulders, and trunk would be upright. So 90 degrees for Fowlers and 45 degrees for semi-Fowlers. This is important for a couple of different reasons. Anyone who's having trouble breathing, also known from this moment forward as dyspnea, would need to be sat in Fowler's position if they were conscious, because breathing is helped when patients are in Fowler's position. Your diaphragm pulls your lungs down. So when you sit the patient up, it allows the diaphragm to work more efficiently in doing so. And so Fowler's position is really important. Semi-Fowler's position is what we put patients in typically if they're having a stroke or if they're having trouble breathing or maybe even chest pain. We don't want those patients lying on their back. So that's why we need semi-Fowlers and Fowlers. Fowlers would be for aggressive trouble breathing. I heard someone raise their hand, so I'm going to come back to the classroom. What do we got, Maria?
How will we position a patient who has a spinal injury?
Spinal injury patients go on supine position onto a long spine board, and we're going to learn how to secure their body and spine in a way that protects it from getting further injury. They would be in supine position. Supine is flat on your back. And there are pictures of these in the book. So you're not just looking from a talking point, you're also receiving a visual. Okay, and you'll see more of that. We'll come back to it more. Who's got a question? Go ahead.
Hey, just for being able to follow along appropriately, is there another spot that you have or is there a different set of Chapter 5 PowerPoint slides? Because I'm following along and it's slightly different than the one you had.
So I got these from, you can see my screen, and I got these directly from Moodle by clicking the slides. So if you go down the Moodle page and you click EMT slides, I pulled them right from here. Now, arguably, so here's where I got it from, and I'm pulling that up. Is that where you got yours from?
Yes, sir.
Okay, just making sure. So we might just be on a different edition. Let me look and see. Let me see what you got going on here.
Generally, it had the same information except for instance, the common direction movement piece has 15 slides on this one and used at 17. Why is that important? Not, ultimately not very much, but there was some information that wasn't in this one that was there.
Okay, let me see why that's different. And of course, it's wanting to open that up only from the internet perspective. I'm just checking for you right now. I don't want to not have done that. So I don't know. I don't think that'll matter much for you. I don't know how they're different, but I will find out. That's Chapter 5 download that I just touched on, I believe. open this PC, downloads. Chapter 5 was downloaded 8 21. I am seeing different dates on these, so that is very interesting to me. I don't know why that would be. Let's go all the way to the bottom and see what this provides. Yet it's not showing any of the other ones. And I'm also seeing something weird happening on my side with the virtual classroom too. It's not allowing me to see the virtual classroom normal. So we'll continue with what we have, and I'll figure that out. I do see what you're talking about. I don't know why it's doing it. I don't even know how it's doing it, but I'll figure it out. The information for sure isn't much different. What we're seeing is there's 11th edition and 12th edition, and you guys are currently on 12th edition. So what I suspect is the slides that you're clicking on right now are 12th edition, and the ones I'm clicking on right now are 11th, and that isn't going to make a big difference to you. Okay?
Yep.
But thanks for telling me, and I'll figure it out somehow, some way. All right, we already talked about that. You will definitely need nephro a lot, which obviously is referencing kidney, and renal also references kidney, which is renal. So nephro and renal mean kidney. We'll use that a lot. By the way, guys, the most important organs in your body is your brain, your heart, your lungs, and your kidneys. And so we're going to talk about those a ton. So nephrology, renal treatment and disease, that stuff is going to be used a lot. Who raised their hand? What you got?
I am only seeing a black screen.
Very good. That's because I played with it and messed with it. Thank you for telling me. Because I would not have known, and I would have gone on forever. You guys are doing really well with that. All right, we see DYS again. DYS is difficulty. So in this case, urea is pretty easy to recognize. That means urine. So this would be difficulty urinating, and that is typical of infections in the bladder, infections in the urethra, infections in the ureters. And so that would be a common symptom that people might have. So you might describe that as dysuria, which could also mean painful. Hyperemesis, we're going to use emesis a lot. The word emesis means vomiting, and hyper anything is a lot of it or too much of it, and hypo anything is too little or too low of it. So hyperglycemia, glycemia means sugar, so that would be high sugar, and hypoglycemia, that would be low blood sugar. So hyper is too much and hypo is too little. So if they were hypoventilated, that means they're not breathing enough. So keep hypo and hyper in your mind. And emesis means to vomit. We're going to use emesis a lot. Abbreviations we don't really use. If you go to a service and they have an actual policy for abbreviations, then you can use those abbreviations. But here's the deal with abbreviations. And you go in court and they ask you what this abbreviation means, and you've used it 5 different ways over the course of 10 years of writing patient care reports, you're not going to be able to defend it. If they can pull a chart and say, well, you used the same abbreviation here, but you're saying it meant something different then, well, that's not defendable. So most agencies don't like you to abbreviate. Most agencies want you to write the entire thing out. So when if you've ever gone to nursing school or anything like that, you've learned a lot of medical abbreviations. And the truth is, they get you into trouble. They can actually cause patients to experience malpractice. We can do stupid things to patients by misunderstanding an abbreviation. So the best way to deal with that is to take it all the way out. So I don't abbreviate in my charts. I don't think you should abbreviate in yours. Best case scenario, you're going to be defending that in 5 years, trying to make them believe you that SOB means shortness of breath instead of son of a blank. All right. Speak up. Answer these questiontos.
Charlie.
Charlie, the most essential meaning of a word is its root. That is true. Prefixes. Which one of these did you see in the slides for prefixes?
Alpha.
Yeah, cyanosis. Cyano was a prefix, and that means blue. So A is a prefix. Plural form of bronchus.
Delta.
Delta is correct. You have bronchi. You have two bronchuses, and that makes them bronchi. The lungs are superior to the bladder, indicates that the lungs are closer to the what?
Delta.
The head.
Ooh, let's go
Belly.
with head. Yeah. Remember, superior is the toppest part of, and so that would be head. Although trunk is proximal, and I get where you were going, superior most point would be the head. So C, Charlie. Movement of the arm towards the midline. If I'm not mistaken, you're adding the arm to the body.
Charlie.
Charlie is correct. Body part that lies closer to the midline when compared to another is considered to be what? So if it's in the middle,
Medial.
it's medial. Used to identify the belly side of something.
Delta.
Yep, it's ventral. Ventral is belly and dorsal is back. The patient is now in semi-Fowler's position. What does that mean?
Charlie.
Charlie.
Charlie, 45-degree angle. If it was Fowler's position or high Fowler's, it would be delta. But this is semi, so that's 45 degrees. Plantar cuts. Where is it at?
Alpha.
Alpha. Alpha.
Very good. Plantar is the foot. Abbreviations, acronyms, and symbols the EMT should. I'll help you. Anytime you have a delta, it's probably delta. And in this case, there are two of these that we know are true. Be familiar with the ones you're going to use, and they have to be in your agency. Well, that makes sense. And use only the ones that are medically acceptable. That makes sense. So since A and B are likely true, then C probably is too. And so then that's delta. I don't like abbreviations. Your agencies are not going to like abbreviations, but it isn't to say that you might not go somewhere where there is an approved set of abbreviations that you can use in order to shorten your documentation. So delta would be the answer. All right, children, let's take a 10-minute break, and I'm going to try to figure out this little slide dilly. We'll come back at 7:40. Take a 10-minute break and complete the last chapter. All right, everyone. I was able to figure out at least 50% of that issue. So I don't understand what's going on in the virtual classroom and why it's not allowing me to present the slides, but I can put it in reading mode. And I did go and find out what was wrong with the 12th edition. So I now have the 12th edition available for you. Even though you have it all available to you as well, you can go and read these slides for yourselves. It doesn't make much difference whether I'm on 11 or 12. There's no testable difference in that. It's just a little bit of additional information or how they set the chapters up. So as far as like what order they went in. So if there's no questions for me, I will do the lecture in reading mode so that I can still see the chat, so I can kind of keep up with what you guys are asking me if you're asking a question in chat. If you're back with me, please raise your hand. We only have, okay, that's 20. We're missing 2 people, Stephanie and Todd. Todd was already in here, so I'll count him. He put up earlier. All right, that's everybody. All right. You should be able to see my screen, and I should be able to see you. So let's go for that. We're now going into the anatomy chapter, and I will just tell you from the beginning that this does not do it justice. You're going to have to read the book. If you have a history in anatomy and physiology, if you've taken Anat 1 and 2 and 3, or gross anatomy, that will be very helpful for you, especially if you've done a cadaver-based anatomy. It's going to be good for you because there's so much physiology to go with this course that I don't think we have enough time to really spend what it's worth on it. So you're going to have to make that difference up for yourself. You're going to have to read this chapter, study this chapter, and I don't think this is a chapter that you're going to just read and study for this module. If I were you, depending on your previous anatomy knowledge, I would spend the entirety of this course really reading through this chapter. You're never going to stop seeing questions that are directly anatomical or physiological in nature. So you've got to spend a lot of time here. You've got to have a background in anatomy and physiology. And if you're starting from zero, you've got your work cut out for you. So here is my FYI message to you. Make sure that this chapter is one you stay in throughout the entirety of the course. All right, so I'm going to go through the material. Unfortunately, for most of you, this isn't material that I can, make shiny and fun and laughable. It's just what it is. And so please try to stay along with me. Don't zone out because you're going to need a ton of this information. And as we go into the lab this week, we're going to really start putting things together with what is V, what is Q, what is hemodynamics, what is shock, and why do they come together? Why is ventilatory related to pump, pipe, and failure? We're going to talk about that stuff, and you're not going to be able to go there with me if you can't visualize the anatomy. So anatomy is the structure in your body. So the heart would be anatomical. And then if we start discussing any way that the heart works, that becomes physiological. So physiological means that it's functioning, it's working. And so a lot of this course is going to be about pathophysiological. Patho means disease. And so if it was anatomically physiologic, then it would be doing what it's supposed to do, and it would be coming from the structure that it's supposed to come from. But if we start getting into the reason they called 911, then obviously that's most likely pathophysiological. What is the disease process here? So understand those terms as we're going to use them aggressively in the class. I'll let you read through this. You don't really need a ton of that. We're not going to discuss the body in coronal, sagittal, mid-sagittal, and transverse planes. That would be more pathology and forensic pathology. We're not really going to do that, so I'm not going to really hit that a lot. But you should know, because it's in the books, and if it's in the book, it's testable. We all should probably know at this point from 8th grade biology that the individual cell is the unit of life, and cells come together in the millions to form tissues, and tissues come together to form organs, and organs come together to form body systems. And you're going to have to think of it on that level because we're going to grow the pathophysiology of this course all the way down to the cellular level. It's kind of easy to talk about the brain in its organ and organ system function because that's macro. But what about when we're getting down into the micro level? We're talking about synapses firing. We're talking about acetylcholine. We're talking about how the brain is actually doing its job. Are you going to be able to go there? And so understanding that micro level of cells and tissues all the way to the macro level of organs and body systems is really important. Know that they do all come together to help us out. The skeletal system is really important, and you're going to learn that it does a lot more than you ever thought that it did in this class. One of the most important functions of the skeletal system for us is actually related to your blood pressure, your blood volume. Where do you get your blood cells from? Well, they come from the medullary space of the skeletal system. And so you got to know that there's 206 bones in the body. The big ones are really dangerous. And if you break them, you're talking about a bunch of hemorrhage. And a lot of people don't know that. They think of the bones as being bones. Well, the bones house a lot of vascular space, and they house a lot of hemorrhage control ability. So when you break a femur, for example, you can lose a liter of blood volume inside of your body. That's not blood that anyone's able to see on the outside of you. And so it's easy to dismiss that. It's easy to forget that it's happening because you can't see it. And so we're going to talk a lot about the skeletal system as to how it works vascularly. In the EMS world, we actually put needles into your bones to give you medications and fluids and blood products to save your life. So that's how vascular the skeletal system is. You can actually function from the humeral head of the upper arm with the equivalent flow rates of a central line. What does that mean to you? It means that that's how much blood is pumping through your arm bone at any given time is enough blood to sustain the rest of your whole body. Did you know that? And if you didn't, now you do, and that should stay in your mind, because when you come up on trauma and patients have large bones that are broken, there's a ton of pathologic nature happening underneath that eyeball that you can't give. You can't see it. You don't feel it happening. It's not something you can stop from happening. So please recognize that. It's really important. The pelvis is really important. So when I give you bones and I say this is how much that bone can lose, you really need to commit that to your note-taking material. So the pelvis, for example, is known to be able to house anywhere from 2 to 3 liters of blood volume. For perspective, people, most of us on the male side have 5 to 6 liters of blood volume. It takes approximately 500 cc's of blood loss for your body to realize there's an issue. So if you're looking at the pelvis, for example, you could lose 2 to 3 liters of blood volume. That is half of what you have to give into the pelvis. That patient is probably not going to survive. So realizing the importance of that could not be understated. Obviously, the skull is the head. The facial bones are really important. If we break the facial bones extensively, the patient cannot be ventilated by artificial means. And so that's going to become really important to you. Lefort fractures are particular types of fractures that happen to the facial bones. And if you feel your face right now, feel underneath your eye, feel around your jawbone, your upper jawbone, all of that is really intact and really solid. Well, imagine a traumatic mechanism that makes that all mush. Well, now you don't really have the airway that you started with, and we can't ventilate against mush. It doesn't hold up to the ventilation artificial methods that we have. So facial bone fractures are a really big deal for us. Obviously, the thorax is the chest. Thorax equals chest. You got to know that. We'll talk about the vertebrae. We'll discuss how many cervical vertebrae you have, how many thoracic, how many lumbar, and we'll learn how to memorize a little tricky way to memorize how many of those you have. I'll leave joints up to you, but that's how those bad boys work. You have them in your upper arms, your knees, everywhere that comes together has a joint bone. The big cranial bones to remember are the frontal bone. That's the forehead. The parietal bones on the side are very tender. They're very susceptible to trauma. You need to remember that. So parietal means the side, and temporal and parietal kind of come together. So when people get hit in the side of their head, anywhere starting from the back of the eye to behind the ear, that's a very dangerous spot to be struck with blunt force trauma, because that's where the bones come together as you move out of the pediatric phase and move into the child phase. Those bones actually come together and seal themselves. Well, that sealing area, we'll call those sutures. That's what the name of those spots are. Your grandmother called them soft spots, and we'll call them fontanelles. So fontanelles are the soft spots where the bones aren't fused together. Well, when they come together and they fuse by creating suturing. And that suturing, although it is strong, it's nowhere near as strong as the frontal bone. It's nowhere near as strong as the occipital bone, which is the back of your head. And so that should be noted by you to be a zone of importance. Make sure you know the frontal bone and make sure you know the occipital bone. We're going to talk a lot about the occiput, which is the back of the head. So you got to know the occiput is the back of the head. The mandible and the maxilla, of course, you've got to know that. So keep those up into mind. When we talk about basilar skull fractures, we're not talking about the back of the head specifically. The occipital bone does wrap underneath the skull to become the basilar skull. Basilar skull fractures are particularly dangerous. They allow cerebral spinal fluid to leak out of the head, which doesn't control good head volume, which means you don't have good head perfusion. You're not getting oxygen to your head. So we're very concerned about occipital and basilar skull fracture. I want you to recognize from what I just told you the difference between the basilar skull, which is the bottom, okay? If you're looking from the foramen magnum and going from side to side, that's the base of your skull. It's not the same, although connected, to the back of your skull. The back is the occiput, underneath is considered the base. So you can't see the base of the skull by looking at a person's head. If you have questions, do speak up. Here are the vertebrae, and there's some really important things to remember about them related to our craft. First, I want to give you breakfast, lunch, and dinner. If you look at the cervical vertebrae, there are 7 of them. So we have breakfast at 7. The thoracic vertebrae, there's 12. Isn't that kind? We have lunch at 12. And if you're an early eater, you're going to do dinner at 5. And so that's the way to remember how many cervical vertebrae, thoracic vertebrae, and lumbar vertebrae that you have. Why do we not really care below the lumbar? Because the spinal cord's not down there, and so we don't really care about it. Does it cause pain? Does it break the sacral area, the coccyx area? Yes, of course it breaks. Yes, it causes pain, but it doesn't house the spinal cord, and so therefore injury potential is much lower after the lumbar vertebrae. If you've ever had any type of cerebral spinal fluid taken from your spinal cord for testing, we did it in the lumbar spine. Why? Because the spinal cord ends in the lumbar space. It doesn't continue past into that space. The thoracic area is really dangerous. The lumbar area gets much more less dangerous as you progress into L1, L2, L3, L4. Okay, so the spinal cord stops in the lumbar spine. That's why we can take cerebral spinal fluid samples from the lumbar region, because we don't have the risk of hitting the spinal cord. So one of the things you should look for in this chapter and otherwise is where exactly, what specific vertebrae does the spinal cord end at? I'm going to leave that to you. That will help you understand why it is that cervical and vertebral thoracic injury are the most dangerous spinal cord related back trauma injuries. Why not lumbar? Why not sacral? Why not coccyx? That's for you to determine. And I just gave you that information. Let's go back to cervical spine and talk about some really important crap. If you want to keep breathing, your cervical 3, 4, and 5 is what keeps you alive. In the middle of cervical 3, 4, and 5, you have the phrenic artery. The phrenic nerve, rather, excuse me. You have the phrenic nerve. The phrenic nerve's job is to innervate the diaphragm. Innervating the diaphragm is what causes you to breathe. So if you were to have a significant interruption of cervical vertebrae 3, 4, and 5, you would then have an interruption of breathing. And so not only would you be at risk of never moving your body again, you would die from not breathing. So keep that in mind. That is why we have such a heavy focus on the cervical spine. If you're looking at the assessment sheet, cervical spine is really high up in the first things that we ever do to people. And you might be thinking, why? Why is that so high up there? It's even before A, B, and C. Why is it so high? Because if the cervical vertebrae 3, 4, and 5 get injured, you will stop breathing. So remember that little saying, cervical 3, 4, and 5 keeps a person alive. And then you need to know why. The phrenic nerve is why. If there are questions, please speak up. So we're going to talk a lot about that. This is a really important slide because we're going to discuss intercostal muscle breathing a lot, which are the muscles that go in between your ribs. Your ribs are designed to protect your heart, lungs, and great vessels, but they serve another purpose. When the diaphragm pulls down to take in a breath, the muscles around your ribs innervate and they pull together and they strengthen up to cause your chest to expand. If that did not occur, you would not have enough strength to inflate your lungs to enough tidal volume to cause a good breath. So when you think about breathing, you now need to think about not only the lungs, but these little muscles that go in between rib 1, 2, 3, 4, 5 on all sides. Those are called intercostal muscles. And those intercostal muscles are responsible for breathing. If they become tired, you're not going to breathe very well. You're not going to take enough volume in your breath. So please remember that breathing is much more to do with your rib cage and your intercostal muscles along with the diaphragm's work than it is the expansion of your lungs. The lungs will expand on their own provided that you can draw enough volume with each breath. It is the intercostal muscle that causes that strength to draw enough breath. As we get tired and we're breathing too fast and we're in breathing distress, those muscles weaken and they stop working. And so then the patient eventually cannot take a breath. I want you to be able to work through that process. We're going to look at the patient's chest. Every time someone has trouble breathing, we're going to take a look at their chest. We're going to expose their chest and we're going to look to see whether or not those muscles are weakening. So that's a big deal. On the bone side of the fence, we have our sternum. The sternum is comprised of three parts: the manubrium, which is the top, the body, and the xiphoid process. You got to remember the xiphoid process because we're going to learn about that in CPR and the fact that if your hands were on that, you could potentially break it off and send it into the underlying major structures like the heart, lungs, and great vessels. That's a pretty big damn deal. So something to keep in mind there. So when you're doing CPR, you'd want to be on the body of the sternum. You'd be in the middle of the breastbone. You would not want to be on the top. You would not want to be on the bottom. And so here's a visual to that. That's pretty good. These collarbones are called your clavicles. We're going to talk about clavicles a lot. There's an imaginary line that goes in the middle of your clavicle and runs all the way down your body, and that's called the midclavicular line. You need to remember that, the midclavicular line. Underneath your armpit, there's an imaginary line that goes all the way down your body called the mid-axillary line. So midclavicular, trying to type too fast, midclavicular and mid-axillary are pretty important zones that you need to know about the body because we're going to talk about those a lot. Your long bones of importance are your humerus, that's the upper arm bone, your ulna and radius, those are the lower arm bones, your femurs, and your tibia and fibia, which are the upper leg and lower leg bones. Those are considered your long bones, and it's important to know that they're long bones because long bones lose the most blood in trauma. Alexa, off. Why the hell does she feel the need to tell me good evening at 8 o'clock? So long bones are really important to know because we are going to...
I'm reminding you, shower time.
That's going to happen 3 times, unfortunately, for all of us.
I'm reminding you, shower time.
I'd change her, but I'm not smart enough to know when the kids should be doing stuff. So...
I'm reminding you, shower time.
All right. So again, got to know those bones because they lose the most blood. I'll let you read that stuff. That's the important stuff for you to keep in mind. Here's a very good visual to why the pelvis is so dangerous. When we break a pelvis, it is a life threat. And this picture is why it's a life threat. The great vessels that perfuse the lower abdomen and the lower extremities go directly through the boniest processes of the pubis. And so if you break this, it's going to interrupt the blood flow, if at best, and at worst, it's going to actually cut open the blood flow. And that, of course, would cause a lot of blood loss into the pelvic area. I want you to see this area here. I think you can see my mouse cursor here. This is called the floor or the book. And the book in nature is closed. You can see that there is the pubic symphysis here. The pubic symphysis job is to keep the pelvis closed. When you get into major accidents and you break your pelvis, one of the worst things that can happen to you is that it breaks back here underneath this acetabulum line, or it breaks through the pubic symphysis and opens up the pelvis. That's called an open book pelvic fracture. That's very dangerous. And the reason it's dangerous is because it's almost always coupled with interruption to the great vessels going through the pelvis, whether that be trauma to the vessels themselves or if they're actually being impeded so that there's no blood movement. Either way, very dangerous. So if a pelvis is unstable, that's a big deal. How are we going to know that to be true? Well, look at this iliac crest up here, these wings, as some people call them, the pelvic wings. That iliac crest is the bone you can feel when you touch your hips. We're going to press it in and we're going to press it down. And if the patient screams out in pain, or even worse, if we feel those bones move or give way, which they shouldn't do, that would be a huge indicator that there's interruption of these vena cava and descending aortic vessels, or that they're actually able to bleed into the pelvis. And so we would bind the pelvis. Basically, we would close the pelvis back with a commercial device, hoping to squeeze off that bleeding. I remind you, the pelvis can lose 2 to 3 liters of volume. That's a lot of blood loss. A patient can die from pelvic fracturing. Here's the promising part of pelvic fractures. In a lot of the literature that you're going to read, you're going to find that 90% of pelvic fracture is venous bleeding. Why is that helpful? Venous bleeding is easier to control. It's not pressurized like the aorta is. And so if we just bind the pelvis, there's a good chance that we will cut off that bleeding and the patient will either have more time, or you'll actually have stopped the bleeding and they can go into surgery. So binding a pelvis is very important. Understanding the pelvic makeup is very important for that reason. I'll let you look at the femur. The femur can lose about 1 liter of blood volume. You're going to see a lot of test questions about the type of muscles because they do different jobs. You need to know that cardiac muscle is automatistic. Automatistic means that it will work on its own. It is automatistic. So your cardiac muscle is one of the only muscular bases in your body that can do its job without being innervated. Now, is that your typical functioning? No, but you need to understand that cardiac muscle is its own ditty, okay? It's its own ditty. It has electrical automaticity. So it can function on its own. Unlike the other muscles, they must be innervated directly by the brain. You're going to see test questions that say, what is the difference between skeletal muscle and smooth muscle? The answer is skeletal muscle is striated. You're going to have to answer that. So striated is skeletal, and striations make the skeletal muscles stronger. Well, that makes sense. Smooth muscles are for passage. So think of urine, think of your gut. Those are smooth muscles, and so in that case, you're passing fluid or, in the case of the gut, other things through your gut via smooth muscle. It doesn't need striation because it's not actually moving an arm or moving a leg. So striated muscle equals skeletal muscle, and skeletal and striated muscle are voluntary muscles. Smooth muscles tend to house sphincters and other mechanisms that are involuntary. Example, In your vascular system, that's smooth muscle. Your vascular system has the ability to clamp off the blood or to squeeze the tank. That would be an involuntary response. There's nothing that you can do to make that happen. So if it's moving an arm, that is skeletal, it's voluntary, and it's striated. Make sure you understand the 3 types of muscle, and make sure you understand how they behave differently, and make sure you can pick what type of muscle they are. If they say this is your ureter, that would be smooth muscle. If they say this is your bicep, well, that would be striated or skeletal muscle because it is innervating your arm. If there are any questions, please speak up. I'll let you look at what the muscles are. And now we're going to get into some of the nitty gritty, the big time stuff that's going to be housing your understanding of A, B, and C, airway, breathing, and circulation. And that is how we're going to look at the patient from a holistic perspective of shock. So a gross understanding of the physical and physiological anatomy of the airway and the breathing is essential. We begin with the airway itself. I want you to notice the larynx first. Go to the larynx on the screen, in your eyes, in your brain, in your body. Just do what I'm saying. Larynx is there, okay? The larynx starts with an L. The lower airway, which also starts with an L, begins at the larynx. You're going to see test questions that differentiate the upper airway from the lower airway. The larynx begins the lower airway. The larynx starts with an L, and so does the word lower. And that's an easy way to remember it. Okay? So the larynx is your voice box, most prominent in men, but girls and boys have a larynx. And it is the opening to your vocal cords and the entranceway into your trachea. So a pretty big deal of a structure. We're going to talk a lot about the larynx. Let's begin with the upper airway now that we know how to differentiate the upper from the lower. Everything behind your nose and mouth and down towards the larynx is considered the pharynx. The pharynx, P-H-A-R-Y-N-E-X. N-X, not an E. There's no E. I created that. You're welcome. So the nasopharynx is just the nose to the pharynx. The oropharynx is just the mouth to the pharynx. And one of the structures that's not on here that's very important is the hypopharynx. What did we say hypo meant? Anyone? Anybody?
Like low.
Yeah, kind of the lowest option, or not enough of, too little, low. So in this case, the hypopharynx would be just above the epiglottis there. Okay, that would be the hypopharynx. This is a really important space for you because that is where you're going to perform orotracheal not tracheal, you're not medics, orosuctioning. So when patients get secretions stuck in their airway that cause them not to be able to move air, it sits in the hypopharynx. You're going to suction the hypopharynx and remove those secretions. And so it's really important for you to realize where the hypopharynx is. Otherwise important is your understanding that hypopharyngeal bulb of the King tube is where that's going to sit. So we look at the King airway and we see the anatomy here that shows you this King airway is seated in the hypopharynx. So it comes behind the tongue here, and this bulb blows up to block the hypopharynx. It keeps the tongue off the back of the airway, and this bulb blows up here in the hypopharynx. So this is called the hypopharyngeal bulb. So that's why this is really important. Remember, the tongue is the most common obstruction of the airway. Look how big the tongue is. What you're able to actually see of the tongue is very little of its actual anatomy. If you get to the base of the tongue, it's very thick, it's very large in mass, And when we become sleepy to unconscious, the tongue will actually rest on the back of the throat and occlude the airway. The tongue is the most common obstruction of the airway. As you can see, this king tube, which is the name of this type of breathing tube that you guys will eventually be taught to put in, it blocks the tongue from doing that. It keeps it from strangling the patient with the tongue occluding the airway. So you need to be quite familiar with the hypopharyngeal space. After we move it out of the hypopharyngeal space, we move into the larynx, which is the opening to the trachea. The epiglottis is above the larynx. The epiglottis's job is the gatekeeper of the trachea. By the time air makes it to your trachea, it is supposed to be warm, and it's supposed to have been sterilized by moving through the turbinates of your nose. The book may show you, if not, go look for it. There are these weird little airway passages in the back of your nose that are moving the air through them turbulently. And there's these little hairs called cilia that are grabbing a hold of stuff that's dirty and not letting it make its way down here to your breathing tube. So by the time the air makes it down to the larynx, it's supposed to be warm, it's supposed to be moist and wet, and it's supposed to have been cleaned. So the gatekeeper is the epiglottis. It rests on top of the trachea most of the time, except when you go to breathe. It opens up and lets air come into your lungs. So you need to know that the epiglottis is the gatekeeper, the protector of the airway. Moving down from the epiglottis, we move into the larynx, which is the opening of the trachea, the vocal cords, if you will. Past the vocal cords, we go into the trachea, which is our breathing tube. The trachea is a hard cartilaginous ringed tube that is kept open by those cartilaginous rings. Unlike the esophagus, which is underneath the trachea, it's flat and it's a smooth muscle. So it doesn't stay open. It normally stays closed unless you're swallowing something. So the trachea is unlike the epiglottis in the fact that it stays open. Obviously, it needs to stay open. So if you feel your throat right now, in the middle of your throat, what you're feeling is your trachea. When you move down the trachea, you come to a bifurcation point, which is where the right lung and the left lung go off into their own areas. We call that bifurcation. And so there's a little spot here noted on this called the carina. The carina starts with a C, and so does the word cough. And that's good because carina is the neurological spot that causes you to cough. It is your last line of defense before the air goes into your lungs. So if something still weren't quite cleaned, it would hit the carina and cause you to cough and expel the dirtiness out. That's the job of the carina. You need to know that the carina rests at the bifurcation point, going from left to right, and you need to know that it causes you to cough. And that's why carina starts with a C. Who has a question?
I have kind of like a weird question.
There is no such thing as a weird question.
Okay, so we were talking about the epiglottis earlier, and I was just wondering, so this is like might be TMI about myself, but I have like an abnormally high sitting epiglottis. Would that like be bad when it comes to like intubation or something?
It would probably make us have to work for it, yeah.
Because like when I like open my mouth, you can like see it. I feel like that's not normal. My doctor
That's a
was
really
like,
good thing for us. It basically would make you easier to intubate, most likely,
Really?
but definitely something we'd want to know about because it could make your airway more anterior. So when we lift up your airway to look at your vocal cords and put a tube in them, sometimes it'll sit too far forward and it's hard to see it. So that might be the case with your airway. So I would say that it would make it a little more challenging, but it might make it even easier. There's tons of anatomical differences that can occur with the trachea, especially in Down syndrome children. that will make it either more difficult or easier to accomplish. So that's a pretty cool little thing about yourself.
Gotcha.
We could do something with you called digital intubation, which is where you actually put in a breathing tube by using your fingers. That's really weird, but in your case, that is very possible.
Hopefully, I never find out.
Yeah, hopefully not. But if so, I hope it's me. I'm just kidding. Intubation is probably our favorite thing to do, so that's why we really like intubation. All right, let's continue down. So, yep, what?
I'm sorry. I had a question about so you're talking about like the reason why we cough and all that. I was wondering, why do sometimes when we are coughing, why do we vomit?
So you can stimulate there's a nerve called the vagus nerve that's in the same areas of these mechanisms. And so sometimes your body doesn't know which one you're doing. And so if you were to cough enough, you would start stimulating that vagus nerve, and that two things would happen. You could pass out, you could vomit, but more importantly, you'll lower your heart rate, which is also a really big deal. So that's why that can go together. Those nerves run down the center space in between the trachea and in the esophagus area. So one of them can trigger the other, which is pretty dangerous. It can get pretty dangerous sometimes to have the vagus nerve stimulated. It will cause vagovasal syncope, where the body, just can't control it, and so it goes unconscious. The good thing is you wake right back up. So it won't be a big deal for very long. But that is why. It's because the anatomy structures are not magic. Wherever they're located is very important. And so one thing can stimulate the other. And that's why that happens.
Okay. Thank you.
Of course. All right. So that's the carina, which is the bifurcation point. You're going off into the left and right lung. This picture doesn't do the left and right lung justice. If it were doing it justice, it would show you on the left side, it would be a 90-degree angle going into that left lung. Here, it looks like the angle of right and left are about the same. Now, remember, I'm talking about the patient's left. So if you're looking at the patient, your right is their left. So over here is the left of the patient. The left lung actually has a pretty sharp turn to go from the bronchus to the lung. The right lung is not that way. It actually is a very mild right hand turn. And so you can actually take breathing tubes and accidentally intubate the right lung instead of intubating the trachea only and ventilating both lungs. You're now only ventilating one lung. And obviously that's very dangerous. If you were taking an entire breath and putting it in only one lung, that would not be a very good thing over a period of time. You could potentially collapse that lung. So one of the things that's really important to think about is it doesn't look like this in real life. That left side takes about a 90-degree turn. The right side is a very low angle, and so then we can accidentally poke things into it. It's also where foreign objects tend to land. Because there's no resistance there, it doesn't take a sharp turn like the left lung does. If you were to swallow, when I say swallow, I mean inhale, a peanut, for example, that peanut would most likely land in the bottom of your right lung because the bifurcation point on the right side is such a mild turn compared to the left side, which is interesting. Okay. You see the intercostal muscles here in between the ribs. Those are responsible for breathing. You need to make sure you keep that in mind. And if the diaphragm and the intercostals become tired, your lungs will still inflame with air. They'll still inflate with air, but you won't be able to inflate them enough. The rigidity of the ribs working in conjunction with the intercostal muscles, that is what causes us to take a deep breath. Very, very important. So keep that in mind. When you think about breathing, you need to be thinking about the ribs. You need to be thinking about the intercostal muscles. Those are really important. And so air, then, everything that we've talked about so far is just ventilation. The movement of air. So air came in through the nasopharynx, came in through the oropharynx. It worked its way down past our epiglottis. It worked its way past the vocal cords into the larynx. We're now in the lower airway, and that air works its way down to the carina. The carina says, okay, you're good enough to go by. It goes by and into the lungs. You need to know that the lungs are ventilating, but in the lower, most lateral fields, only about 20% of lung space, we house alveoli. And that is where the actual oxygen respiration occurs. Alveoli are the little air-filled sacs, and wrapped around those air-filled sacs is all that vascular goodness, all of that capillary and venous bed flow that allows you to bring on oxygen and give off carbon dioxide. You need to know that this picture on the right-hand corner of the alveoli is happening only in the most lateral and inferior portions of the lungs, which account for about 20% of lung space. Why is that really important to you? It's important to you because if the breath that you took didn't result in chest rise and fall, then you only ventilated the lungs, but not enough to get the air down to the alveoli. You need to think of them as kind of hiding down in the bottom spaces there. And our job is to get the air down to them so that they can actually exchange gases. So when we harp on tidal volume later, you're going to hear tidal volume a lot. Tidal volume equals chest rise. Okay, you need to know that. That's going to be a constant test question. It's a constant talking point. Tidal volume equals chest rise. If we don't see visible bilateral chest rise, we can assume that the ventilation wasn't positive enough to cause oxygenation. So that is why chest rise and fall is so important. Did the air that we're ventilating get far enough down into the lungs to cause respiration? So sometimes you'll see people doing a lot of breathing, but that breathing is not resulting in taking on oxygen and giving off carbon dioxide. And so then it's useless. We call that a VQ mismatch, and we're going to talk about that later as to what that actually means. But just know that people can breathe and breathe a lot, but that breathing is not very effective. It's not actually taking on oxygen and releasing carbon dioxide. And that is when people run into shock. That is how people get into trouble and potentially die. Listen, let's take 5 minutes. Some of you probably already have your eyes crossed and you're writing notes to Jesus as to why you would have taken this class. I hope not. Take a break. Let's do about 5 minutes and let's come on back and keep lecturing this very, very important message. It's 8:23 now, so we'll do 8:20. I'll just do 30. I'll do 8:30. We'll do 7 minutes, okay? 8:30. Okay, people, we're back. We're back. Let's carry on. All right, we were discussing the alveoli and their job of taking on oxygen and giving off carbon dioxide. And so then that brings us into the conversation of ventilation versus respiration. Ventilation versus respiration. And before I get to that real quick, because that's going to be a big topic, I want to show you a constant question that you're going to see. And I don't know why they harp on this, but they do. They want you to know that the thyroid cartilage is before the cricoid cartilage. And so I'll bring you over to a picture of that bad boy. Let's see if they have one. There we go. There's a picture. I don't know why they care. I know why they would care if you were paramedics, because you'd be cutting a hole in this area, but you're not. So I'm not sure why they harp on it. But I'm going to help you remember it. Thyroid is on top of cricoid cartilage. And you can remember that because thyroid starts with a T and top starts with a T. So you're going to see a test question that says, is cricoid superior or inferior to the thyroid cartilage? And the answer is the cricoid cartilage is inferior to the thyroid cartilage. In between the two is the membrane that we would cut a hole into and put in a breathing tube if for whatever reason we could not intubate you. That is called a surgical cricothyrotomy, where we actually open up this little hole and put a breathing tube in there. So that would be between the thyroid cartilage and the cricoid cartilage. And that is a test question. Thyroid starts with a T, and so does top. Top also starts with a T. All right, so I want to quickly touch on, before we go any further, the difference between ventilation and respiration. Ventilation is the movement of air, period. And the movement of air occurs everywhere in the lungs, to even include the alveoli. So normally if you say the word alveoli to someone and you say, where does respiration take place? They'll say alveoli. But they also don't remind themselves that ventilation takes place in the alveoli. So you're going to see a test question that says, basically, what is ventilation? And ventilation is the movement of air. You move air into your nose and mouth, down your throat. You move air into the lungs. You move air through the alveoli. So just because it's occurring at the alveoli does not make it respiration. If the test question is talking about taking on oxygen and giving off carbon dioxide, that is respiration. Respiration is the exchange of our gases by diffusion. Okay? The exchange of oxygen and carbon dioxide via diffusion. Diffusion is important to remember here because diffusion is a process that doesn't require work. So then it only happens if it's just present. It either is there or it's not there. If for whatever reason there was no oxygen to take on, then it just wouldn't occur. Or there was no carbon dioxide to give off, it just wouldn't occur. So you need to remember, at the alveoli, we are ventilating. If the question is talking about the movement of air, choose ventilating. If the question is talking about the actual exchange of the gases, choose respiration. Ventilation and respiration happen in ratio. V to Q. The ratio should be 1 to 1. You need to remember that. And that makes sense. For every time you ventilate, you should respirate. Imagine if it took a 2 to 1 ratio. That means you are working twice as hard for the same amount of respiration. That will not work. It will not pay off. A VQ mismatch is shock, and that patient is going to die if that is not corrected. The ratio must be 1 to 1 between V and Q. V equals ventilation. Q equals respiration, and we're going to call that perfusion, and we'll talk a lot about that later. You don't need to remember that right now. Okay, Q equals respiration. And so that ratio is best when it's 1-to-1. Moving forward, I think you know you have 2 lungs. That's great. The pleura is really important, okay? The pleura is the lining around the lungs that protects the inner cavity from fluid, from air, anything else besides lungs. There should be nothing in the lung space externally but the lung. The pleura is a sterile compartment, a little liner, a little layer that makes sure there's nothing else in there but lung. If we go back over here to the anatomy picture, the pleura is right on the outside of the lungs, but underneath the ribs. So if the pleura were to get a hole in it, this space would fill up with air, and that air would work against the expansion of the lungs. That's going to become very important later. So the pleura is the lining that protects the lungs. You need to know that. Muscle breathing, you need to make sure you remember what we've talked about with intercostal muscles, okay? The muscles in between the ribs. Remember that breathing is a negative process. You have a negative pressure atmosphere inside of your body. The diaphragm pulls down and creates a vacuum in your body that sucks air from the outside into you. That's very important to remember because artificial ventilation works exactly opposite of that, which means it is costly. There are negatives to positive pressure ventilation. You breathe negative pressure ventilation physiologically, and we breathe for people via positive pressure. You need to remember from this moment forward that PPV stands for positive pressure ventilation, and it's artificial ventilation. So you are breathing for the patient. We are supposed to breathe via negative pressure ventilation, where the diaphragm pulls down and a vacuum is created inside the lungs, and it sucks air from the outside environment inside of you. When you switch a patient from negative pressure ventilation to positive pressure ventilation, there are some difficulties that occur, to include death if not managed correctly. So when we discuss lab positive pressure ventilation in the lab this week, we're going to discuss how you can kill someone with that BVM, the bag valve mask, the Ambu bag that you see on Grey's Anatomy. That thing is a weapon and it will kill people. And we're going to discuss how that's true. And it's based on the physiology that it's opposing the normal physiological breathing process. And because it does, there are some negative things that will occur. Inhalation is when we bring air into our bodies, and exhalation is when we let the air out of our bodies. Inhalation is performed under work. It is active. It requires energy. Exhalation is passive, and it does not require energy. So then there is a ratio for that as well, called the I to E ratio. In the I to E ratio, we're typically looking at 1-to-2. And you can look at the I to E ratio in period of time so that it's easy to remember. In general, since inhalation is an active process, it would take place over the course of 1 second. But exhalation, being passive, probably takes place over the course of 2 seconds, or twice as long as that of inhalation. Why is that important? When patients start breathing really fast, which is a normal mechanism to compensation, anytime the body runs into trouble, they're going to become tachypnic. We remember that tachy means fast and pnea means breathing. They become tachypnic. So when the patient becomes tachypnic, that ratio now goes to 1:1. 1:1 is not enough time to let out the carbon dioxide. So you got in the oxygen, but because the ratio of inhalation to exhalation is off, you're now not 1:2, you're 1:1. And so then you're not giving the body enough time to breathe off that carbon dioxide. Carbon dioxide is an acid. It is hydrogen ion-based acid, and it is causing us to become acidotic. Your body cannot be acidotic. So to run into breathing trouble is this huge cyclic event where you are getting worse and worse and worse. And that is why airway and breathing are such a significant component of emergency and critical care medicine. If a person is allowed to continue in this high rate of breathing with a ratio of I to E to 1:1, or even worse, and a ratio of V to Q of 2:1, where you're not getting respiration for every breath, that patient is going to die if we don't correct that issue. So you have two sides of the coin. You have ventilation emergencies and you have respiration emergencies. We treat ventilation emergencies by either breathing for the patient ourselves or by assisting the patient's breathing in some ways we're going to talk about in the future. We treat respiration emergencies with making sure there's enough oxygen for the patient to actually use in their ventilation. This is going to get more and more and more complex, and you're going to get to the point where you can diagnose whether a patient is experiencing a ventilatory emergency or a respiratory emergency, because we treat those emergencies differently. If you were to treat them the same, you wouldn't be effective over a long period of time. And the patients in distress do not have a long period of time. So remember, inhalation is fast, it is active, it requires work, it's difficult. Exhalation is supposed to be passive, double the time of inhalation, and it doesn't require work. So it is natural and it must be allowed to exist. So if anything impedes it, we run into trouble because it's so passive. I want you to know that we don't breathe because we need oxygen. What? Justin, all my life I've been told that wrong. You were. I'm sorry. Your parents did not go to college. Well, maybe they did, but they didn't take any sciences classes. We don't breathe because we need oxygen unless you are a very chronically ill patient. We breathe because we have too much carbon dioxide on our bodies. I told you that carbon dioxide was an acid. Your body has little receptors all over it, mostly in some specific areas that aren't really important right now, but there are some receptors that are constantly measuring your pH. pH of the human being, or their acid level, is typically 7.35 to 7.45, as noted in all of your anatomical classes you've taken thus far. And so all the time, round the clock, your body is saying, am I between 7.35 and 7.45? Am I between 7.35 and 7.45? And if you're not, it starts doing things to try to get back to that, okay? You need to know that that's how we breathe. We do not breathe because we need oxygen. Our bodies tell ourselves to breathe when we get too much carbon dioxide inside of us and they need to release it. Our lungs need to release it. That is what stimulates us to breathe, okay? I'm going to leave the term at the bottom here, hypoxic drive, alone, except to say this. The word hypoxia equals not enough oxygen. We know that oxygen is two oxygen molecules together, and carbon dioxide is a carbon and an oxygen molecule together. I'll leave it at that. I don't want to get you into the cyclic cycle and how that happens, the citric cycle, and why we were able to produce CO2 in the bloodstream. So I'll leave that alone and stay where we are right now. So you're going to see a test question that says, why do we breathe? And the answer is we have too much carbon dioxide. That's why we breathe. You need to know that the nervous system does control our breathing, and that happens in the brain stem. The brain stem is the medulla oblongata and the pons. The medulla and the pons control our breathing. If you aren't breathing, the medulla oblongata and the pons are not happy. And so that's how we breathe. We get too much carbon dioxide, and the medulla says, breathe. And then you do. We already talked about that. We talked about tidal volume. And so this slide brings us into, now that I know how it's happening, now that I know a little bit of why it's happening, how can I measure it to say that it's happening effectively? And that, my friends, is what minute volume is. The adult breathes 12 to 20 times per minute. That's the rate of breathing of the healthy adult. You need to know that. If that's true, every time we breathe, we have tidal volume. I told you that tidal volume equals chest rise. That's what I said. So if we breathe 12 to 20 times a minute, and every breath that we breathe has chest rise, which is tidal volume, then that is measurable over 60 seconds. The average adult breathes 4 to 6 cc's per kg of air. When we talk about medicine, we talk about a reference patient of 100 kgs. We do not measure patients in pounds, so you're going to have to get out of that. We'll discuss that in just a minute. So the reference patient for medicine is 100 kgs, which is approximately 220 pounds. So we're talking about an adult male. Let's go with that. So then let's keep this topic going. 20 times a minute, 4 to 6 cc's per kg. Let's make the math easy. Let's say you're breathing 20 times a minute, and it's 4 cc's per kg. That brings us to 400 cc's of air in every breath. So 20 times a minute, 400 cc's of air every single time you breathe. Then minute volume would be the amount of that air over the total minute. So 20 times 400. And so what would that bring you to? I want you to do the math real quick. What would the minute volume be for a patient breathing 20 times a minute at 400 cc's per breath? Anybody? It would be 8 liters. Very good. Mazara, I think. I suck at that. It would be 8.0 liters, which is the same as 8,000 cc's of air. You need to know that a cc is equivalent to an ml, a milliliter. And so 8,000 milliliters is the same as 8.0 liters because there are 1,000 mLs in 1 liter. So minute volume is typically 4 to 8 liters per minute. If you weren't moving that much air over the course of a minute, you would not be oxygenating well. I told you earlier that V to Q needs to be 1 to 1. I told you that I to E needs to be 1 to 2. If V to Q is 1 to 1, if I to E is 1 to 2, then minute volume should be 4 to 8 liters per minute. That is how we measure the patient's breathing. You need to know how to calculate minute volume. It's the rate of breathing times the amount of volume in each breath over the course of 1 minute. If there are questions, please speak up. Normal breathing rate is 12 to 20 breaths per minute for the adult patient. We normally see visible chest rise and fall. Breathing rhythm is typically regular. And breathing is a passive art. You're not really supposed to hear a bunch of noise. You're not really supposed to see the patient working hard to breathe. It's very passive. In fact, if you were looking at most people and talking to them in a classroom, you wouldn't be noticing them breathing on a typical basis. That would be characteristic of normal breathing. When we get outside of 12 to 20 times a minute, when our breathing is not regular, when our breathing is not passive, it becomes labored. We're working hard to breathe. So when we measure someone's breathing, we measure it in RRQ. RRQ. Rate, rhythm, quality. Rate should be 12 to 20. Rhythm, regular. Quality, which is how we describe things, should be unlabored, passive. It shouldn't be very noticeable. A bad breathing rate, rhythm, and quality, by example, would be 24, labored, meaning they're working hard to breathe, and irregular. That would be a bad breathing finding. Any questions? If you want to know if they're respirating, you have to be good at checking their ventilating. Moving on. You need to know that when people are not breathing well, they give off some characteristics that are common. Cyanosis is blue coloring of the skin. That's common. Unfortunately, it's late, so we'll discuss the limitations of that. Tripod position is when people put their hands on their knees and they try to elongate their chest, because remember, the diaphragm pulls down. And so the longer I can make my thorax, the easier it is to breathe, or at least the easier it feels to breathe. And so it's very common for us to see patients who are having trouble breathing in tripod position. You need to know that agonal gasps are a sign of cardiac arrest. It means that breathing has been so bad for so long that the patient is now completely ineffective. Agonal gasps are typically slow, and they literally look like someone gasping for air, and they're typically unconscious, unresponsive, and normally that would be an indication to begin CPR, cardiopulmonary resuscitation. So agonal breaths are slow, are deadly, and they're very gaspy. They're literally the last thing that your body is trying to do to get air. It's not going to be effective, and you're going to die if that is not corrected. All right, we move away from breathing and we go into the circulatory system if you're still alive. The circulatory system from now on is going to be referred to as the pump, pipes, and the fluid. That's the circulatory system. The heart, which is a pump, the pipes, which are the vessels, and fluid, which we know is blood made up of volume, red cells, and white cells, and platelets, which causes clotting. Not spell. Right. So if you want to know about the circulatory system, is it doing well? Then we got to assess the pump, the pipes, and the vessels, and the fluid. That's the pump and the pipe are the same things, vessels and pipe. So you got to assess them from that perspective. Pump, pipes, fluid. That's how we're going to talk about it. The pump's job is to move blood all the way around the body. And first it moves it with the heart and lungs, and then it moves it to everywhere else. You're going to need to know the actual flow of blood through the heart, which we're going to talk about right now. So the two big vessels that you need to know are the vena cava. This is the vena cava. You have a superior end and an inferior end. And then the aorta. You need to remember that veins, any vein, no matter how large or small, are low pressure and they're not pulsatile. They carry blood to the heart. Arteries are under great pressure. They are pulsatile and they carry blood away from the heart. So, accepting fetal development, we're talking about a normal human. The arteries carry blood away from the heart, and that blood is oxygenated. The veins carry blood to the heart, and that blood is deoxygenated. That is why it looks so dark. That's why it looks so lacking in vibrance, versus arterial blood, which is bright red and gorgeous. It looks so oxygenated because it is. The only artery in the non-fetal patient that carries deoxygenated blood is the pulmonary artery, because all arteries carry blood away from the heart. So if that's true, then this vessel here taking blood from the heart to the lungs is by definition an artery. However, it's the only one that is carrying deoxygenated or poorly oxygenated blood, and it's taking it to the lungs to be oxygenated. Okie dokie. So then the pulmonary veins are the only veins that carry oxygenated blood in the non-fetal patient. You got to know that information in order to know the blood flow through the heart. Blood flow returns to the atrium on the right side. So this is the right heart here. Blood flow returns via the vena cava on the right atrium. It goes from the right atrium to the right ventricle, from the right ventricle out to the lungs, from the lungs to the left atrium, from the left atrium to the left ventricle, from the left ventricle throughout the body. You have got to know that or you will not pass this class. So if you need to look on YouTube for tracing of the heart flow, do that. If you can do it from the book, do that. If you can draw it yourself time and time again, do that. But you have got to understand how blood returns to the heart and how blood is pumped away from the heart in order to understand a bunch of the problems that go wrong with it. Okay? Again, the upper chambers of the heart are atrium. The lower chambers of the heart are ventricles. The left ventricle is the strongest part of the heart, and that's because it's responsible for pumping blood out to the rest of the body. Okay? You're going to get questions about heart valves. There are valves from every chamber to another chamber. So the atrium to the ventricles, there are valves. You see the valve right here. This is a valve. Okay, you try before you buy. Remember that, because on the right side of the heart is the tricuspid valve. That's what that is. That little flappy flap right there is the tricuspid valve. It's on the right side of the heart. You try before you buy. This is a bicuspid valve on the left heart. So if you get asked, where is the tricuspid valve? Remember that blood flow returns on the right side of the heart first, and so you try before you buy. Any questions? Beautiful. Moving forward. Just like we measured the breathing, we're going to measure the pump. The heart rate of a normal adult is 60 to 100, as you can see here on the screen. And stroke volume is equivalent to tidal volume. In tidal volume, it was the amount of air going into the lungs. In stroke volume, it's the amount of blood going out of the heart. So we measure it the same. Rate times volume. In the minute volume, it was rate of breathing times volume per breath over a minute. Here, it's the rate of the heartbeat times the stroke over a minute. So on average, our heart is capable of pumping 70 cc's of blood with each pump. So let's make the math easy. We have 100 beats per minute at 70 cc's per beat. What is my cardiac output? The answer is easily 7 liters, right? You come out with 7,000 cc's. And that makes sense because cardiac output is typically 5 to 7, maybe even 4 to 8 liters of volume per minute. I told you that the most volume adults tend to have is 6 liters in their whole body. So if you're looking at that math, you're moving your entire body's blood volume through the heart every minute, or at least most, depending on your particulars, every minute. That's a lot of work for the heart, and that should give you some inclination of how easy the breakdown will become if there's a problem with rate or stroke volume. Stroke volume is the amount of blood that comes out at a time, and the rate should be 60 to 100. If the rate was 54, we would call that bradycardic. Bradycardic. Cardiac is heart. If the rate was 120, we would call that tachycardic. Tachy, fast, cardiac, heart, fast heart. Remember those words? You need to know that the pump is not only mechanical, but is also electrical. Next Wednesday, or tomorrow and Thursday, we're going to learn that one of the most common problems with the heart that's deadly is that the conduction system fails. If that happens, the patient will go into an arrhythmia and they will die. One of the largest and most deadly complications of cardiac function is a lethal arrhythmia, acute onset arrhythmia, and you will die right now. The only thing that will solve that problem is to shock it into a normal rhythm. So when you think about us shocking people's hearts, that's what we're doing. The mechanical heart can be well. It can be happy and capable of doing its job. But if the electrical conduction of the heart is not well, then it doesn't send the appropriate signals for the pump to do its job effectively. So you need both sides of the coin. You need a pump that's mechanically well, and you need a conduction system that is electrically well. If those things are not true, they cannot work independent of one another. That's not true, but I can't tell you right now. I have to tell you later. But for whatever you're understanding at this moment, one needs the other. And if there's a breakdown, the patient probably is going to look pretty sick, if not go into arrest. Okay? The conduction system works from the top of the heart down the middle of the heart. And you need to know that the pacemaker of the heart is called the SA node, the sinoatrial node. And it's just a little piece of tissue that we call the pacemaker. The pacemaker keeps the heart beating at one specific set of normal rate, which is 60 to 100 beats per minute. The sinoatrial node is found physiologically in the upper right atrium. You need to know that. We've already talked about arteries and veins. Remember that arteries are under pressure, and so they're carrying oxygenated blood. That is where you see systolic blood pressure. So the systolic blood pressure is the top number. It should be 120. And then 80 is the diastolic. So 120 is looking at the pressure in arteries. 80 millimeters of mercury, if that's what it was, if that's what the diastole was, which is the bottom number of your heart, is looking at the pressure in your veins. So 120 is arterial and 80 is venous. These arteries and veins go everywhere inside of you, big to small. Capillary equals capillary equals an artery. Venule equals a vein. So they're very, very small. Capillaries are arteries that are very, very small. And venules are veins that are very, very, very small. They go all throughout your body, including your heart. The coronary arteries perfuse the heart during diastole. Heart is perfused during diastole, which is the bottom blood pressure number. That's your 80 millimeters of mercury. That's when the heart gets its own blood. So that's a very crucial time period, and we're going to talk a lot about that. Before this class, you probably didn't think much of the bottom number. It was the top number that gets everyone's attention. But that bottom number is when the heart itself is receiving oxygenated blood via the coronary arteries. Coronary arteries equals heart vessels. They get their blood in diastole. So if diastole doesn't go well, the heart itself will begin to die, and we call that a heart attack. If the coronary arteries are blocked or the coronary arteries do not get enough blood, you would have a heart attack, a myocardial infarction. Remember, the pulmonary artery is the only artery, because it's carrying blood that's not oxygenated, from the right the right ventricle to the lungs. So it's the only artery in the, we'll just say adult patient, the non-fetal patient, that carry, I should stop having to clarify that. I think you get the point by now. So it's the only artery that carries low oxygen blood. Every other artery in our bodies carries really high oxygenated blood. All right, pulses that matter. Carotid, those are the ones in your throat. Radial, those are the ones that are connected to your wrist. And femoral, those are the ones down by your groin. Let's talk about pulses and why they matter. If a patient is conscious, I'm just going to misspell and y'all are just going to like it. Check a radial all the time. If they're unconscious, check carotid. Let's find these pulses on ourselves. Everyone feel your trachea. That's the breathing tube in the middle. Everyone feel your trachea. Keep your fingers on your trachea. Now I want you to walk into the groove right beside your trachea and feel for a second or two. On each side of your trachea, you have a carotid, a right carotid and a left carotid. Those are the arteries sending oxygenated blood to your brain. And that's a pulse point that we really need to be comfortable and capable of checking. If you don't have that pulse point, speak up and I'll help you find it. But one of the ways I like to teach people is walk into the ditch. The trachea has a ditch on each side of it. Think of the trachea as a pipe. And right beside the pipe on left and right is a ditch. The carotid arteries are in the ditch. Okie dokie? Let's talk about why that's so important after I tell you how to find your radial pulse. Okay, radial pulse. Turn your hand towards your face so palmar surface is up towards you. And I want you to follow your thumb down to your wrist and press in the hole on the thumb side. You should be able to find your radial. If not, we'll work on it tomorrow in lab when we have a visual with each other. The radial and the carotid are arguably the most important pulses. On conscious people, we check radial pulses. On unconscious people, we check carotid pulses. Let's talk about why. Based on where that pulse is how likely it will perfuse in an emergency. Obviously, your hands are far away from your heart. If you can feel a radial pulse, the blood pressure is at least 80 to 90 systolic. If you can feel a radial pulse, their brain is being perfused and they have at least probably more towards the 90-100 range. But for good measure, we're going to call it 80-90, okay? The literature is all over the place on that number, statistically speaking, but let's just use it as a foundation. So having a radial pulse is a very positive sign for blood pressure. If they've got a radial pulse, they've got enough blood pressure to perfuse the brain. That's the point to be taken away. Not necessarily what does that equal in systolic number. Boo-hoo, who cares? What it means is that if you have a radial, you likely have enough blood pressure to be perfusing the brain. The brain is hard to perfuse. It sits on top of us. So it's hard to get the blood up there because it's the most anti-gravitational spot on our bodies. So if you got a radial pulse, you've got brain perfusion, and that's the point to take away. If you've got a carotid pulse, but you don't have a radial pulse, the patient's blood pressure is much lower and the patient is much sicker. So that's kind of how we think about that. You're going to see us constantly checking radial pulses because we want to know if the patient has one. And if they do, then they have perfusion to the brain. And that makes us know that even if that blood pressure number was a little on the low end and I didn't really like it, they're still getting blood to the brain, and that's a really good positive. We'll talk more about that. You need to know that the spleen and the liver are solid organs that filter blood. I'm going to kind of stop there because I don't want to get any deeper than that. But you do need to know the difference between hollow organs and solid organs. You're going to see test questions about that. I think that's pretty easy, but maybe not. Most people don't know that the pancreas is a solid organ. Well, it is. The bladder is hollow. The gallbladder is hollow. Anything that holds fluid, anything that holds is a holding area, that is going to be hollow. Anything that's filtering and moving, volume is going to be a very solid. So kidney, solid. Spleen, solid. Liver, solid. Bladder, hollow. If a solid organ gets injured, it lacerates. If a hollow organ gets injured, it ruptures, it pops. Okay, so think about that. You're going to see test questions about that. Well, what would happen to blunt force trauma to the upper right quadrant? You would lacerate the liver. Because it's solid, it'll tear. Or in this case, we'll call that tear a laceration. So we learned about the pump. We learned about the pipes. Now let's learn about the volume. We already said the volume is made up mostly of your plasma, which we're going to call volume, because your volume is what moves the red cells, the white cells, and the platelets. If you didn't have 70% volume, then that good stuff would just sit, and that's bad. It'll clot and you'll die. So you need a lot of plasma. Hypovolemic. Okay? Hypovolemic. That's low volume. Everyone thinks about folks bleeding out, and that's their only thought of hypovolemic. Hypovolemia is a cause of death. It's dangerous, it's deadly, and one of the most common reasons to be hypovolemic is not from bleeding. It's from losing your plasma via dehydration. One of the leading causes of death in the entire world is diarrhea. Uncorrected vomiting and diarrhea for 72 hours can result in death. One of the largest killers of children in the world, not necessarily in our country, is diarrhea. There are still a large amount of children living in spaces on the earth where diarrhea is a leading cause of death. You cannot underestimate the necessity of that 70% volume in blood product. Without it, you're hypovolemic, and if you're hypovolemic, the blood doesn't go anywhere. The cells, the platelets, they sit still, they don't go, and you die. So dehydration is a huge killer. One of the best ways to become dehydrated is uncontrolled vomiting and diarrhea. Remember that the red cells are erythrocytes, the white cells are leukocytes, the red blood cells carry oxygen, the white blood cells fight infection, and the platelets are used to clot, to keep us from bleeding to death. Okay, that's a very basic understanding, because I'm going to tell you, one of the most miraculous things on the planet is our blood volume and the amount of jobs that each portion of it actually undertakes every single day. Blood pressure, again, is the left ventricle squeezing and relaxing. When the left ventricle squeezes, that's systole. Systole also is known as beat. So your top number, your 120, that's systole. Your diastole is the resting phase, when the heart actually receives its own blood. So that's resting, and that's your 80 millimeters of mercury. That's your bottom number when the heart is relaxed. Okay? Squeeze, 120. Relax, 80. 120, 80, 120, 80, 120, 80. That's how it works. And if it doesn't work like that, it goes very poorly, very quickly. You got to know what systole is and what diastole is. We're going to learn to take manual blood pressures in class. If all of that we just discussed goes well, you are homeostatic. If any of that we just discussed goes poorly, you are hypoperfused. Hypoperfusion is the big medical word for the shock that you knew before this class. If the body is in shock, it actually means it's hypoperfused. Every single cell inside of you must receive oxygen, sugar, and appropriate amounts of fluid in order to carry on their daily jobs that you never know are happening. If for any reason at all, any amount of cells inside of your body stop receiving adequate perfusion, you are in shock. The most aggressive definition of shock is the hypoperfusion of cellular level, which is then tissue level, which is then organs, which is then organ systems. That is the best, most micro definition of shock, which you're going to be asked a lot of times. Someone asks you what is shock, your answer is hypoperfusion. You can get into the categories. You can get into what tissues are involved. You can get into the etiology, which is the cause of the shock. You can get into all that. But the message to take home is that every single cell needs all of this stuff every single time. And if any of them don't get it, it's hypoperfusion, and that is shock. Our job as EMTs is to recognize hypoperfusion as early as possible and try to reverse it in order to buy the patient time for corrective action to save their life. That's our job. Any questions? This is more of what the blood volume is doing, which is a lot of stuff. All right. Getting into the nervous system. Thank God we're getting there. The nervous system has two sides, fight or flight and rest and digest. The sympathetic system is fight or flight, and that's your epinephrine, your adrenaline, your norepinephrine, or what we'll know to come to be levofed. That is your body's way of responding to emergencies. So the epinephrine gets your heart fast, and it gets it squeezing hard, and it gets it to do its job more efficiently. The norepinephrine squeezes the pipes. You got to know that. Epinephrine drives the heart aggressively, and norepinephrine squeezes the tank. If the heart's pumping faster and it's pumping stronger and the tank squeezes harder, the blood pressure is going to go up. And hopefully you would decrease hypoperfusion. That is called compensation. Compensation is when our bodies correctly dump epinephrine and norepinephrine into our system, sympathetic fight or flight, and we attempt to push the heart harder squeeze the tank harder, and raise the blood pressure so that more parts of us get the oxygen they so deeply deserve. So don't forget that sympathetic is fight or flight. Your rest and digest is the parasympathetic system. That's going to be an easy test question. Sympathetic is the big stuff, the crazy stuff, the fight, the flight. The parasympathetic is the resting, your GI tract, your taking on of nutrients from fuel, from food. That's all parasympathetic stuff. That's all gut stuff. But if you were going to respond to an emergency, that's all fight or flight, and that's sympathetic. So sympathetic, fight or flight, parasympathetic, rest and digest. I'll let you look at the CNS versus the PNS. I hope you already know that. Central versus peripheral. Peripheral means arms and legs. We'll just go with that for now. This is our brain. The cerebrum is the big brain. The cerebellum is the little brain. Remember that. Big brain, cerebrum. Little brain, cerebellum. One of the ways I used to remember that is that it's opposite. The word cerebellum is bigger than cerebrum, which is opposite of the actual anatomy. So the bigger word goes with the smaller brain. If that helps you, great. If it doesn't, dump it. Cerebrum is big brain, cerebellum is little brain. The brain stem that you're seeing there is the medulla oblongata and the pons. I want you to notice that the brainstem is just superior to the foramen magnum, which is the hole in the bottom of your head. If the intracranial pressure inside of your head got really high, it could force the brainstem through the hole in your skull and you would die. We're going to learn a lot about that later, called Cushing's triad. So know your anatomy: cerebrum, cerebellum, brainstem, which is the medulla oblongata, and the pons. The medulla and the pons control breathing and have an inflection on heart rate. In your brain, we say it's the 80-10-10 rule. 80% of your brain space is brain. 10% of it is blood going through the brain and around the brain. The other 10% is the bathing of cerebral spinal fluid that keeps everything moist and slick so that nothing sticks to itself and tears off or runs into trauma. Okay? That's the 80-10-10 rule. You don't have a lot of room in your head. You only have enough room for brain, blood, and CSF. So if that blood starts bleeding outside of the brain into the cranium, you're going to die. We're going to talk a lot about that. Look at that spinal cord. Notice that it stops. The spinal cord stops at thoracic 1. In this case, T12, if you're looking inferiorly. Somatic means body. So that's your somatic nervous system, how you feel. Autonomic nervous system is basically your body's computer chips, where it's saying, is everything going all right? Do I need to do something else? Do I need to squeeze the tank more? Do I need to pump the heart more? Do I need to tell the medulla to breathe more? So think of the somatic nervous system as macro. That's your hands and your feet and your feeling, and I can feel what I'm doing. Autonomic is that very crucial inside stuff that's happening very quickly, more like a computer, and you don't really see it happening, but it is, and it's super aggressive, and it's how you respond to emergencies. So somatic is outside periphery, and autonomic is your sympathetic and parasympathetic system. I'm going to leave that there. The skin, I'm going to harp on a lot. The skin is the integumentary system, and it is the largest organ in our bodies. You need to know that the skin is responsible for temperature control, fluid balance. It keeps your fluid in the right places, and barrier protection from illness. Arguably, the skin is one of the most important organs you have in your body, and any breakdown of the integumentary system would result in hypovolemia, hypothermia, and sepsis, which is gross body infection. You need to remember those things. The skin protects you from hypovolemia, which is low volume, hypothermia, which is low temperature, and sepsis, which is gross bloodborne infection. That's what would happen if you didn't have your skin. That's what happens to burn patients who are burned more than 20% of their body. They become hypovolemic, they become hypothermic, and they die of sepsis. Questions? Better stop me if you need to. I could go all night. This is my favorite stuff. Let me know. I'll leave that alone for now. Those are the big points to take away from the skin. The GI tract I'm going to let you read. I've already taught you about the organs that are really important. Obviously, GI is a specialty. It's very important and a lot of stuff that's going on. The big thing I'll tell you is your large intestine, which is this big thing you see in purple, which arguably is much shorter than the small intestine, which is odd. The large intestine is not responsible for the absorption of nutrients. It's responsible for fluid in the gut and kind of moving things along. So the small intestine is where you get all of your nutrients. That's why it's so much longer. It takes so much more time for things to move through it because absorption takes time. And you can tell that the large intestine doesn't do much absorption because there's not enough of it. The pancreas is definitely a digestive organ worth talking about. It does secrete material that helps in the digestion process, but most importantly, it maintains our sugar balance, our glucose balance. The pancreas secretes insulin and we'll just say sugar for now because we're going to dig into that a little deeper, and sugar in a certain way. And the body has to take that sugar and insulin to the cells. Insulin is the gatekeeper. Sugar molecules are too big to get into the cells by themselves, so they need a gatekeeper. Insulin is that gatekeeper. So you've got sugar floating around in the bloodstream, and insulin goes out there and says, hey, sugar, get inside the cell. Come on, come in here with me. If you don't have insulin, then the blood sugar is really high because it's not in the cell, it's in the blood. Sugar shouldn't be in the blood, it should be in the cell. If it's inside the cell, it's being used, and it's being used to create energy. If it's outside of the cell in the blood, it's not being used, it's just sitting there, and it causes a lot of bad things to happen. So if the pancreas doesn't work correctly, that's a pretty big deal, okay? Pretty big deal. Yes, Mizra, that is true. The spinal cord technically ends in a measurable manner in L2. Not really useful to us. So I'm going to leave that anatomically alone, but just know that past the thoracic vertebrae, the spinal cord's measurable encounter with trauma or measurable encounter with medical procedures is not
I'm reminding you, bedtime.
very high. So that's why I would go with that kind of understanding. It's kind of easier than to identify and memorize lumbar 2. But feel free.
I'm reminding you, bedtime.
So yes, you are right. And it wouldn't be T9, it would be T12. Remember we have, hold on.
I'm reminding you, bedtime.
We have 12 thoracic vertebrae. And so I would consider the measurable ending of the spinal cord to be at the end of the thoracic vertebrae. But yes, for testing purposes, that would be lumbar 2. We typically try to get cerebral spinal fluid specimens in 3 to 5, L3 to 5. And so that's why they're doing it there. If you've ever wondered why it's so low, it's because your risk of hitting the spinal cord is very limited in that region. It's not absent, it's limited. So that's the pancreas. We're going to come to know a lot about the pancreas. Who doesn't love the pancreas? It's just delicious. I'll leave that alone for now. The lymphatic system, I'll let you read. There's not a lot of lymphatic emergencies that we see. They exist, but they're not a lot of them. They're normally complications of other things like chemotherapy, cancer, third spacing. We'll talk about those things. You do need to pay attention to the endocrine system itself because you are going to get asked what particular hormones do what. So I would pay attention to that. I wouldn't get super deep. The ones I would pay a lot more attention to are the hypothalamus, which is controlling temperature, and I would pay attention to the pituitary gland. Of course, they're all an amount of their importance, but I'm trying to give you what I think will most likely show up on the testing material because some of you don't have a huge background in anatomy, and I don't want you knee deep into the parathyroids when I know the pituitary would likely show up. The urinary system is another big organ that I'm going to harp on because, again, your brain, your heart, your lungs, your kidneys are the most important organs in your body. If you are not making urine, you are dying, period. The average adult, male at least, makes about half a cc to 1.5 cc's of urine per kg per hour. What does that mean? It means the body is constantly ridding itself of pH imbalance and toxins. You do that via your kidneys, which are solid filtering organs, and they create glomerular filtration rate, which empties out a bunch of toxin, and then you pee it outside of your body and you go on about your business. The inability to do this because of sudden onset medical or traumatic emergencies is a big damn deal to us. Measuring a patient's output is very indicative of their hemodynamic status. Hemodynamic means the consistent function of all of those involved. The ventilatory status, respiratory status, pump, pipe, fluid, and the kidney output. The kidney output is very indicative of the patient's global wellness. So we measure output. It's important to ask patients, have you been peeing normally? When's the last time you peed? Has it hurt? Was it bleeding? Did it come with any odors? These are very valuable questions to the emergency patient population because if you're peeing, you're living. And if you're not peeing, something is going on that I need to find and pay attention to. If you're on a football field wearing football gear for 7 hours, practicing in 90-degree heat, and the last time you peed was, I don't remember, you are hypovolemic. And that is probably why I'm here today. If I were to miss the urination output of that patient, I'd probably miss their emergency altogether. So pay attention to kidneys. Kidneys also secrete erythropoietin, which is what stimulates us to make red blood cells. So the kidneys are very diverse. If you run into end-stage renal disease, you not only can die from the toxins that build up in your body, you also are not regulating your blood pressure, you're not regulating pH, and you're not secreting erythropoietin, which is responsible for creating red blood cells. And if you don't have red blood cells, you don't oxygenate. So I can't understate the importance of the frickin' kidneys and the fact that we haven't given them the attention in 8th grade biology that they deserve. I'll leave the female and male genitalia anatomy alone because we're going to cover the most common emergencies that occur with them. And they both get their own chapters. Not the male anatomy doesn't necessarily get its own chapter, but it's touched on in a specific space, versus the female anatomy is going to get its own chapter. So I'll reserve that conversation for that time. Just know that the most common female anatomy genitalia related emergency is ectopic pregnancy, which I discussed with you. I think the uterus is super cute. If you've ever seen the uterus on a laparoscopic view, it actually is very small and it looks like a cow's head. When it becomes implanted with a fetus, of course, it gets very large and very protective. And I just think that's really incredible. Probably one of the most incredible aspects of medicine is GYN and OB care. So we'll familiarize ourselves with all of that in due time. We already talked about the life support chain and how we oxygenate. You need to know that if metabolism, which is perfusion, if that is occurring in the presence of oxygen, it's aerobic. If it's occurring outside of the presence of oxygen, it's anaerobic, and anaerobic metabolism results in death, period. And so our metabolism should occur with high concentrations of oxygen. In the absence of that, we are hypoperfused and we are not able to aerobically metabolize, which means we're going to die. Anaerobic metabolism is deadly. It will buy you time, but it will kill you. Hypoxia, I remind you, is the lack of oxygen. Hypercarbia is too much carbon dioxide. If a person stops breathing, they will become hypoxic and hypercarbic because we exhale carbon dioxide and we breathe in oxygen. Please understand that the ventilatory cessation of a patient would result in hypoxia and hypercarbia. These are the things that cause ventilation, respiration, pump, pipe, and fluid failure. And we have discussed them already. So make sure you're reading this. Let's get to the questiontos. The retroperitoneal space is the weird space that sits in the back of us between the anterior and posterior. Very good, most of you. The retroperitoneal space is, in this case, most kidneys. The pancreas and kidneys are your most typical organs talked about in the retroperitoneal space. The kidneys rest solely in the space, and the pancreas is partly in the space. So that's the retroperitoneal space. Typical signs and symptoms of retroperitoneal insult, either medical or trauma, would be flank pain. Flank is considered the lateral sides and back of you. So if you went to your ribs and you followed your ribs around to your back where they end, they're kind of still there, but you're making a circle now. That's your flank. And anytime the patient is complaining of flank pain, we think of retroperitoneal space. And when it says tip, it means not top or bottom. Correct. The xiphoid process is the cartilaginous tip of the sternum, which is actually on the bottom. Very good. That's bilateral, so that means both of them. If you were looking at a neck, what is the most forward identifiable mark? The answer is C. Remember, thyroid cartilage comes on top. It's the first mark. It's the Adam's apple, more prominent in men than in women. Thyroid cartilage. Insulin is produced in the what? That's an easy one. Pancreas. Blank connects muscles to bone. MTB. MTB. Tendons, baby. It's BLB and MTB. Muscle to bone is muscle, tendon, bone. And bone is connected to other bone via ligaments, BLB. So always remember MTB. Muscle to bone, muscle, tendon, bone. Normal resting heart rate is? Bravo, very good. The left atrium receives blood from where? The left atrium, remember the patient's left. It receives oxygenated blood from the lungs because the right atrium receives from the vena cava. So very good, everyone. The largest part of the brain is the shorter word. The cerebrum is the largest part of the brain. That is that gray and white matter. Which of the following statements about red blood cells is not true? They do not help fight infection, which is not true. They do help fight infection, but we're going to go with it. The point is, white blood cells are solely responsible for infection fighting, and that's what they're trying to tell you. So don't get too nitty gritty. Don't read into it. C would be the better choice out of those options. Woo-wee. If that wasn't long enough for you, it was long enough for me. So I will see you in lab both Wednesday and Thursday, where we will do BLS resuscitation. I would advise you to watch this lecture twice because it's a lot of the meat and potatoes of what we're going to build on. It is the foundation for which we will discuss hypovolemic shock, cardiogenic shock, neurogenic shock, and obstructive shock. So if you're going to learn about those things, you've got to have a strong foundation to build on. And most importantly, if you're going to intervene in those things, you've got to have a strong foundation to build upon. So go through the slides, read the anatomy chapter word for word, do a lot of studying. This is a big amount of where we're going from here. So please give it your attention and your love. I know that you will. Any questions for me? Faith Pinckney, I don't know if I put you here. Let me double check. Faith Pinckney, I did not. What time did you get in, Faith? You were not here when I called roll.
Yeah, my connection was coming in and out. I got here at 6:45.
Okay. No worries. All right, everybody. Good night, friends. I will see you at lab. Be safe.
Thank you.
Thank you.
Thank you.
Thank you.
You are currently the only person in this conference.